Hey guys, can you hear me? Can you see me? If so, say me hi and a hello. Guys, can you hear me? Am I audible? Am I visible? I hope I am. So let's start today's discussion. So, how many of you guys are here live? There are very little audience. Hello, Dr. Sri. Good afternoon. How was Puja? I hope it is good. Great. Fine. Super. So what we are going to do is we will have a quick T&D. I hope you gave the test. How was the test? Good, bad, ugly? Should be good, right? But it was a bit of an easy set of questions. I had equal distribution of both one line type of question and also a bit of a simple clinical scenarios, right? If not very difficult, very simple clinical scenarios, right? And most of them are either PYQ from an FMG or a PYQ from a NEET PG and a little bit of questions from INICT as well, fine? So let's see. Let's discuss quickly what all things are. Let's make this very short and simple and let's make it more interactive, right? More we learn, more we interact, obviously we're going to learn more, fine? So this is the first question. The characteristic feature of acute inflammation is everyone online, A, B, C or D. What is the right answer? A, B, C or D. What's the right answer? Obviously it is. Okay, Dr. Nitin has started. She started. It's A, right? It's a very simple question. The characteristic feature of every acute inflammation throughout the body is vasodilatation and increase in vascular permeability, right? If the question comes, which is the earliest feature of acute inflammation? The earliest feature is in vasoconstriction, right? Because let's say if someone is going to come and hit you, what will be the first response? You will try to protect or hit back? Obviously you'll try to protect, right? So any inflammation for that matter, when I have any bacteria, virus, fungi or any injury coming inside, my vessel will try to constrict first. That's a very transient one. It's earliest and it's a very transient one. Obviously the ultimate thing is vasodilatation and increase in vascular permeability. This is true for acute inflammation throughout the body. I'm going to teach you how to generalize few things because learning concepts, repeating the same concepts every subject, every chapter does not make sense. I read one concept and we apply it to multiple places because that's much easier to extrapolate and to learn as well, right? So acute inflammation, I'm just going to write a few things. You tell me whether it's an acute inflammation or not. Rhinitis. Is it an acute inflammation? Yes, no. Meningitis. Is it an acute inflammation? Yes. Pneumonia. Is it an acute inflammation? Yes. All these three are classical examples of acute inflammation, right? Vasodilatation of the nose results in plugging of nose. The nose becomes blocked. Increased secretion, increased vascular permeability. Meningitis, when the secretion in the CNS increase, what do you think will happen? You'll have increased CSF pressure, irritation of the meninges, your 𝐒𝐿 and everything. Pneumonia is a lung infection. More congested lung and more permeability. Obviously, the entire lung will be full with fluid, which results in breathing difficulty, right? So this acute inflammation of vasodilation, increased vascular permeability can be extrapolated throughout the body, acute inflammations, right? Now let's have a quick look about few important things in acute and chronic inflammation, right? So acute inflammation, obviously the difference is this is going to be in hours to days, sorry, minutes to hours maximum. It will not go beyond that, the insult. So this can be from days, can be months, can be years as well, chronic inflammation, right? Can anyone tell me what's a cell of acute inflammation? When I say cell, the inflammatory cell. What is the inflammatory cell for an acute inflammation? It's a very simple question. Inflammatory cell for an acute inflammation. It's neutrophil, right? It's neutrophil. Can anyone tell me what is the inflammatory cell for chronic inflammation? Chronic inflammation, generally we mistake and call as something else, right? I have 5 or 6 WBCs maximum. Tell me whatever comes to your mind. Chronic inflammation is going to be macrophages. Please don't write as lymphocytes. Lymphocytes are not the cell of chronic inflammation. Macrophage is a cell of chronic inflammation. But yes, we do have lymphocytes also. If the chronic inflammation is due to a viral etiology or if it's due to an autoimmune etiology, then I'm going to think about lymphocytes, right? Remember this. I'll tell you how to extrapolate to multiple things. Just few information is enough for us to learn things, right? Hallmark of acute inflammation, like we read, vasodilatation and increase in the vascular permeability. Hallmark of chronic inflammation, this is my favorite thing, TDHF. TDHF stands for tissue destruction, and healing by fibrosis, right? This is the hallmark of every chronic inflammation throughout the body, right? I want everyone here to comment, interact. Can I tell tuberculosis as a chronic inflammation? Yes or no? Can I call TB as a chronic inflammation? Yes, undoubtedly, right? So if you had remembered this X-ray finding of chest X-ray finding of tuberculosis, have you heard about something called a fibrocavity lesion? Yes, you must have, right? So fibrocavity lesion is nothing but tuberculosis. So which means in the lung, I'm going to have tissue destruction. That's the cavity. Heals by fibrosis. That's fibrocavity. This is true for every chronic inflammation throughout the body. It will be tissue destruction and healing by fibrosis. Microscopy will have macrophage and lymphocytes if it's due to viral autoimmune etiology, and neutrophils and vascular permeability is the hallmark, right? Now let's have a quick look at all the inflammatory cells. This slide is very important for you. I'll share the PDF later. Take a screenshot of this and put it as your wallpaper for a couple of days, fine? Okay. So how do I identify neutrophil in a biopsy? Whatever I'm going to give you clue are clues in biopsy, not in a blood. Blood has different appearance, biopsy has different appearance, right? What is the color of nucleus? Anyone? Pink or blue? What do you think will be the color of nucleus in a biopsy? Pink or blue? Everywhere nucleus is going to be perfect, it will be blue in color, right? So when you have a bent nuclei, when the nuclei is kind of bent, it's like this, right? We call it a neutrophil, right? I'll just zoom this image. Can I call this cell a neutrophil? Everyone, yes or no? There are multiple smileys there, right? At least say thumbs up, 100%, whatever it is. Can I call this a neutrophil? Yes, you can call it a neutrophil, right? So whenever any biopsy is given, can you identify a simple neutrophil? You can definitely identify a simple neutrophil, right? Nathan, remember, if something nucleus will always be blue in color, it will not be pink in color. Anything which has DNA and RNA will be blue in color, right? So it has bent nuclei. Eosinophil, in a biopsy, they'll have pink granules. It's granules, not pink in color, right? If you have pink granules, I'm going to call it a eosinophil. All these are your eosinophils, right? All the cells with multiple pink granules, right? Now, if you have remembered your first year or your very early days when you read about physiology and these blood cells, you must have read that eosinophils is bilobed, right? Spectacle shaped or a headphone shaped nuclei. In a biopsy, don't expect that. You won't see that for the simple reason, this is spectacle, right? If I cut it like this, I will see two lobes. If I cut it like this, you will see only one lobe. So don't go with the lobe for a eosinophil. Always go with granules in a biopsy for an eosinophil, right? Lymphocyte is an agranulocyte. It's a small, round, blue cell. Just wait with me for next 2-3 minutes. We'll make beautiful extrapolations of all whatever we have studied, right? All these are my lymphocytes. The entire thing here, they are small, round and blue. That's how a lymphocyte looks like. Small, round, blue cells morphology, fine? Okay. Macrophage. Let's go to plasma cells. Plasma cells has a very unique appearance, fine? Okay, Dr. Sri, I don't have the control to do the ads. Sometimes YouTube does or sometimes PW does, right? So I'll tell them to do that, fine. Okay, fine, let's go here. So plasma cell, it's an elongated cell, okay, with a nucleus in the corner, right? It'll be an elongated cell where nucleus will be in the corner, and surrounding the nucleus, it has a very faint halo. There'll be halo surrounding the nucleus and it'll have a pink cytoplasm. That's how the plasma cell looks like. Okay, I'll just show you a plasma cell, right? A cell which is elongated, a cell which is oval, nucleus towards the corner, right? And I'm sure you must have seen a tiny bit of halo, not a very clear wide space, but definitely close to the nucleus. There's a tiny bit of halo. That's how a plasma cell looks like, fine? Okay, macrophage has clear cytoplasm because the function of macrophage is to eat everything. So once it eats the dead tissue is primarily made of lipid and plasma membrane and everything, right? So it has clear cytoplasm. Basophil will have very coarse blue granules. Okay, so these are the inflammatory cells, right? Let's quickly go through. A bent nuclei for a neutrophil, pink granules for an eosinophil, small round blue cells for a lymphocyte, elongated cell, corner nuclei, halo for a plasma cell, clear cytoplasm for a macrophage, and very coarse blue granules. These are the coarse blue granules. This for the basophil. Fine. Right. Now let's make superb extrapolations of all these things. Right. If a question comes to you saying the patient had basophilia, what's the first diagnosis which comes to your mind? That's the only diagnosis I want you to think of. Basophilia, increase in number of basophil. There's a leukemia which has basophilia. Anyone, what leukemia has that? There's leukemia which has basophilia. CML, right? So whenever you see the question with basophilia, do not think of anything else, just only one diagnosis: chronic myeloid leukemia. That's all. Be it an exam, NEET PG, FMGE, INICT, or even in real life, it's CML. CML for basophilia. So you have cells like this, multiple granules, you think of a CML. Fine, perfect. Now, can I say Hashimoto's thyroiditis to be an autoimmune disorder? Yes or no? Hashimoto's autoimmune, yes or no? Definitely yes. What is the cell of autoimmune disorder? Neutrophil, eosinophil, lymphocyte, plasma cell, macrophage. What is the cell? Lymphocyte, right? So when I see a thyroid biopsy or a thyroid FNAC with cells like small round blue cell, can I think of an Hashimoto's thyroiditis? That's how you correlate, right? You know a disease which is autoimmune disorder. Our goal is to identify image-based questions. That's all, right? So autoimmune disorder will have lymphocytes. So a thyroid with lymphocytes, I think of an Hashimoto's thyroiditis, right? I'll twist the question a little bit. Graves' disease, autoimmune or not autoimmune? Graves' disease of thyroid, it's also autoimmune disorder, right? So can I say Graves also will have the same small round blue cells or lymphocytes? It will also have. So now tell me, how do you differentiate Graves' disease versus a Hashimoto's thyroiditis? Both are autoimmune, both will involve the thyroid. How do you differentiate? It's a very easy way to differentiate. If you are stuck in the microscopy, go back to the patient. Graves is hyperthyroidism or hypothyroidism? Perfect, Rahul. That's all. So when I'm stuck at something, you will have the symptom of hyper or hypo. Graves is hyper, Hashimoto is hypo, but both of them in microscopy, I'm going to have lymphocytes destroying the thyroid. That's all. That's how you extrapolate. Can I say, I'll change one more way to apply this. Fine. A patient with a salivary gland swelling and lacrimal gland swelling, salivary gland biopsy shows lymphocytes destroying the salivary gland. Which means it's an autoimmune condition. What do you think is the diagnosis? You might have heard this disease in other words called as keratoconjunctivitis sicca. Autoimmune disorder destroying the salivary gland, lacrimal gland, Sjogren's syndrome, right? So have you heard about the syndrome called as Sjogren's syndrome? Sjogren's syndrome is an autoimmune disease which destroys salivary gland and lacrimal gland, right? So ideally, it's very, very simple for us to identify microscopy if you see what you're looking for, right? I'll add one more question here. I'm having a blood vessel wall with lots and lots of macrophage in it, right? Can I say it's a chronic inflammation of blood vessel? And the patient is having heart attack. Patient presents with a heart attack or a stroke, and the blood vessel is having lots and lots of macrophage. What will be the diagnosis? Heart attack or stroke, blood vessel wall having a chronic inflammation full of macrophage. Can I say atherosclerosis? You can pick up atherosclerosis, right? So atherosclerosis will have all these macrophage here, right? So this is my macrophage, clear cytoplasm. So it's easy to mix and match whenever a clinical scenario comes. Fine. Okay. Hello, assalamu alaikum. Okay. So now if you have eosinophil, I'm just giving you a random history. Vasculitis involving eosinophils. You might have heard about a syndrome called as Schock-Strauss syndrome. It's a type of vasculitis, right? That will have eosinophils. Asthma, bronchial biopsy with eosinophils. I think of asthma. Any hypersensitivity type 1, I'll think of eosinophils only, right? So it's very simple to extrapolate if you remember this. These 6 things, never forget. Read the question, look at the options and try to solve it. Fine. Okay, that's a little bit about your inflammation things. Fine. As a second question, oxygen dependent killing is done through which of the following? What's the answer? Whatever comes to your mind, A, B, C or D. Don't hesitate. Comment A, B, C or D, doesn't matter. Anyway, you have 25% of getting it right, right? Atul, Rahul and Dr. Sri, NADPH oxidase. Obviously it's right? Oxygen dependent killing mechanism happens via NADPH oxidase only, right? Let's quickly go through the killing mechanism of oxygen dependent killing, or we use the term respiratory burst. Okay, there are two things. We call it respiratory burst or an oxygen dependent killing mechanism. It's based on oxygen. Like you guys said, when the NADPH oxidase acts on the oxygen, it produces O2 minus. O2 minus is called as a superoxide. Once superoxide comes into the body, I will have an enzyme called as an SOD, which is superoxide dismutase. It will react with superoxide. That's all, right? It's superoxide dismutase. Once superoxide dismutase acts on it, it will become hydrogen peroxide, H2O2. Hydrogen peroxide has two outcomes based on what my stimulus is. If bacteria is stimulating, what WBC will come into place? Neutrophil or eosinophil? I'm having a bacterial infection. Obviously, I have neutrophils, right? So in neutrophils, I have excess of one of the enzymes called an MPO, myeloperoxidase, which will bind with chlorine and produce HOCl minus. HOCl minus, hypochlorous ion, is the most effective bactericidal. This also has come in an exam. It's very, very effective bactericidal, right? All these things you need not read from books. You know for a fact it's bactericidal. Have you used Dettol, Lysol, Phenyl, something? All of them have hypochlorous acid. That's all. Advertisement. It kills 99.9% bacteria because it's a very, very effective bactericidal, right? Same. HOCl, when you go and work in the hospital, if a blood spills, you pour HOCl on that, wait for 10 minutes. It'll kill almost every bacteria there. So it's not infectious, right? If let's say I'm having a patient with parasitic infection, what WBC will come into play? It's your eosinophils, right? If it's eosinophils, I'll have a different outcome, right? If it's eosinophils, I have a protein called as major basic protein. It's an enzyme like myeloperoxidase. With iodine, it forms HOI, and this destroys parasites. Okay, they are destroy the chitins of the parasites, right? So that's why I have different WBCs for different infections and inflammations, because HOCl cannot destroy parasites, HOI cannot destroy bacteria. That's why I have two different cells and two different things, right? So this is what exactly respiratory burst is. There's no fun in reading this because this will not give me disease. This will prevent disease. If it prevents disease, that's not doctor's job, right? Our job is to diagnose disease and treat disease, right? Now let's see if NADPH oxidase is not present. Listen carefully and answer one by one. If NADPH oxidase is not present, do you think acute inflammation will happen? Not happen? Yes or no? Genetically, I'm not having the enzyme. No acute inflammation. Perfect. If there's no acute inflammation, can I say every inflammation will become chronic? Is the statement right? I had a bacteria, no acute inflammation, everything became chronic. If everything becomes chronic, can I say everything will be like TB? TB is chronic inflammation, right? What's the microscopic finding in tuberculosis? It's a very basic, simple question. So when NADPH oxidase is not there, every disease becomes chronic and every disease looks like tuberculosis. Tuberculosis is a chronic bacterial infection. Microscopic appearance is granuloma. So if NADPH oxidase is not there, can I call the disease chronic granulomatous disease? That's all. That's one of the disease, right? We have a disease called as CGD or chronic granulomatous disease. Here, there's a defect in NADPH oxidase. Okay, it's chronic granulomatous disease. The name comes based on the problems, right? In this disease, there I have two types of inheritance. It has both autosomal recessive and X-linked recessive inheritance, dual inheritance, fine. And I have this patients will have recurrent infections as a symptom. That's how the symptom will be, right? And I do have one more classical finding, a test called an NBT test. Just remember this. This is a test used to diagnose chronic granulomatous disease. Nitro blue tetrasolium, NBT. Just remember NBT test, a test used to diagnose chronic granulomatous disease. Fine. Okay. Now let's go back to the same thing again here. So now, if MPO is not there, will I be able to destroy HOCl or produce HOCl? No. I'll have a disease, right? That's MPO deficiency. Bacterial infection cannot be cleared, right? So I have one more disease which is called an MPO deficiency. There's also an autosomal recessive inheritance. Remember, most of the enzymes are autosomal recessive only, right? Here you'll have very insignificant or very slight bacterial infection and candida, because candida, superficial candidas are removed by this, right? And here the way to diagnose or investigation of choices, enzyme analysis. Analyze the enzyme, you will be able to clearly, easily identify them. Fine, that's how it is. Okay, great, Bharat. Okay, DHR I didn't tell for the only reason DHR is not available in real life. That's the reason I didn't go with DHR. NBD is a test which has been done for chronic granulomatous disease. DHR for textbooks. You will read many things in textbooks, not just in pathology, something goes in gold standard, right? Gold standards never exist in real life. In real life, you always use which is economical at the end of the day, right? I cannot say that I have to do a functional MRI to diagnose Parkinson's. We use very simple clinical examination to diagnose Parkinson's, right? But you are completely right, okay? Then I have something called Čidiac-Kagashi syndrome. This is an autosomal recessive inheritance again, okay? With a mutation in a gene called an LYST gene. Fine. So LYST gene is a mutation. Because of this mutation, LYSE stands for lysosomal transporter. It transports. Okay. It's lysosomal transporter. Fine. So it fuses the lysosome and the phagosome. Right. Because of this, I'll have obviously recurrent infections. That will be there. That will be the classical finding here. These patients will not be able to fuse the phagolysosome complex, so bacteria cannot be killed. So bacteria enters the WBC and destroys the WBC, right? So these patients will end up in having neutropenia. There's a classical finding here. In addition to this, the other findings are very classical. Okay. Now, can anyone tell me? Bharat has told the answer. I'm going to tell you why it's going to cause albinism. If you remember your anatomy, can I say that melanocytes do not rise from epidermis? What is the embryology of melanocytes? Anyone? Melanocytes embryology, they come from neural crest derivatives, right? Melanocytes are from neural crest derivatives, right? Perfect. Same as your Schwann cells, am I right? Schwann cells also come from neural crest derivative, which means from the neural crest, the melanocytes should come to my skin. It has to move, right? If it's not moving, only the neural crest will be black. My skin will not be black. My toe will not be black. For that movement, I require this transporter. So if the transporter is not there, do you think melanocytes can move from neural crest to my skin? It cannot. If they are not able to move, what will be the color? Like Bharat said, albinism, right? There are a few other findings. One is the patient ends in having an albinism. The only good thing about knowing the reason is you need not memorize. I know it's a transporter. Transport of melanocytes is also defective. I won't have pigmentation, albinism. Transport of Schwann cells also will be defective. Schwann cells helps in myelination. Nerves will not be myelinated, hence in having peripheral neuropathy. Okay. Peripheral neuropathy is a classical finding of Čidiac-Kagashi syndrome. Albinism along with your recurrent infections are classical findings of Čidiac-Kagashi syndrome, right? Then just two things. LAD. LAD, I'm sure you know the expansion. Leukocyte adhesion deficiencies. I have three types. Third type is just for MCQ. Ignore it, not very important. 1, 2 is also very rare, right? LAD1 is a defect in integrin. Maybe remember I for 1, like 1, right? It's an integrin defect. Okay. What do you think is LAD2? What defect will be LAD2? LAD1 is integrin defect. LAD2 is, by default, you will be tempted to say selectin defect, right? It is Cialal-Lewis X defect. It's not selectin defect because selectins are seen in endothelium. These are leukocytes problem, not the endothelium's problem, right? LAD1 is integrin defect, this is selectin defect. Both of them are autosomal recessive. Okay. Remember, both of them has a very unique quality in terms of presentation. When I have an immunodeficiency disorder, all these are deficiency disorders, right? What will happen to WBC count? Will it be reduced or will it be elevated? In terms of immunodeficiency disorder, reduced or elevated? It will be reduced. but these both will have neutrophilia. That's common for both. Both of these patients will have increased WBC count, right? Because the cells cannot go outside because of defect in cell your rolling and adhesion, right? And like Bharat said, there are few extra findings. LAD1, integrin also helps in wound healing, right? So there's a delayed healing, or we call it delayed separation, right? Okay, delayed separation of umbilical cord. It's actually delayed healing of umbilical cord because healing is mediated a little bit by integrin, right? Because first injury, you, me, and every human being has got is injury in the umbilical cord. When I say delayed separation, this is my baby's tummy. This is the umbilical cord which has been clamped. This falling is delayed separation. Umbilicus is nothing but a scar. This scar is going to heal very, very slowly. Fine. I'll answer, but just give me a second. Like that, I have finding for LAD2. The patient will have a type of blood group called as an Bombay blood group. Okay. Bharat, the patients will have neutrophilia, both of these patients, because, okay, I want everyone to answer here. Integrin and CLL-6 or selectin, what process are they involved? They are involved in the process of rolling, adhesion, diaphoresis, right? That's the process where the integrin, selectin, or CLL-6 is involved, right? So if you remember, let's say I'm having a blood vessel like this, where my neutrophil is there inside, right? My neutrophil is there inside. This patient is not having CLL-6 or not having integrin. So can these WBC go outside, or they can't go outside? They can't go outside. That's the problem, right? So I had an infection. WBC knows there's an infection. My neutrophil cannot go outside because of the defect. If my neutrophil is not going outside, not removing the bacteria, what will the bone marrow do? Produce more neutrophil or less neutrophil? Because it's not able to remove that. So it keeps on producing more and more and more and more neutrophil. In spite of producing more neutrophil, can they go outside? They can't go outside because of defects in your selectin, integrins, and the rolling and adhesion process, right? So now I'm taking blood sample. So what will the blood sample show? More WBC or less WBC? Obviously, more WBC, right? It will definitely show more WBC because then exit defect, not the formation is it. There's an exit defect, that's how there will be no more WBC. Fine, Bharat? Okay. This table might come handy. Again, remember this, take a screenshot, keep it. This also might come handy for us to extrapolate things, right? Few questions in inflammation chapter. Okay, looks big. This is a neat PG question. Tell me the answer. What do you think is the answer? Come on, A, B, C, or D. A, B, C, D, I want everyone to come in because 25% you still have right. D. Great. I'm not able to see the, just give me a second. Okay, so it's a classical case of an anthracosis, right? Nothing much to read this. Please don't write melanin. Most of your seniors, when this question came for the first time, it's an impulse, right? Black pigment, melanoma, malignancy, it'll attract you because when I diagnose something rare or exotic, it gives an ego boost for us, right? Don't fall for that, right? Now tell me honestly, let's read the question. It's a 69-year-old patient, came with cough and fatigability, weight loss, diagnosed to be squamous cell carcinoma on bronchoscopy, right? So it means in the lung, in the bronchus somewhere. The sector specimen of the hilar lymph node shows a black area. Tell me, first question, melanoma. Do you think melanoma is common in bronchus or esophagus? Or it's very, very, very rare? It's very, very rare, right? You generally don't see melanoma in bronchus or esophagus area, right? Melanoma can be seen in skin. It will not be seen in these areas, right? It's very, very rare. Moreover, melanoma or melanin, the color of melanin is not black, it's brown. Microscopy, it will be brown in color, it will not be black in color. Your skin, my skin, we have brown color pigment. Maybe if it's very, very concentrated, like in an African person, it might become black, right? So what's a black pigment? It's undoubtedly your anthracotic pigment or your coal. Your hilar lymph node, my hilar lymph node will be black in color only because we have been inhaling all the polluted air. You cannot change it, right? Now this question gives us an opportunity to discuss about pigments, fine? So these are the 4 pigments which we want you to remember, and I'll give you clues and you will tell me any more stains if it's helpful in diagnosing few conditions, right? Lipofuscin, all these are brown color except for carbon. Carbon will be a black color pigment. Rest everything here is brown color. Lipofuscin, which condition you can see lipofuscin? It's not condition related, it's old age related, right? Perfect. Lipofuscin is a wear and tear pigment. More older you become, more amount of lipofuscin, it'll keep on accumulating. That's how it is, right? If I have a microscopy, all these clues are microscopic clues. I'm writing MX for microscopy. If you see a pigment which is brown in color in the paranuclear location on either sides of the nucleus, I think of a lipofuscin. I do have a stain for lipofuscin. I'm not saying that. Just remember, paranuclear brown color, old age, no history, just old age is lipofuscin, right? Hemosiderin, again, books say it's golden brown color, but I'm not sure. Golden brown and brown, will you be able to differentiate? It's brown in color, that's all, right? Can anyone tell me the special stain for hemosiderin? Hemosiderin or iron is positive for one thing, which is it's positive for Pearl's Prussian blue, right? It's positive for Pearl's Prussian blue, right? Perfect. Which condition do you see lots and lots of accumulation of hemosiderin? Great. Any condition where you see lots and accumulation of hemosiderin? Hemosiderin accumulation will be seen in case of your hemochromatosis, hemosiderosis by default, right? If I give you a history which says you are having an hemosiderin deposit in the lung alveoli, in the macrophage of lung alveoli, what will be a diagnosis? It will be seen in a condition called as heart failure cells. Heart failure cells are seen in case of a chronic heart failure or a chronic pulmonary edema, where you'll have this, fine, lots and lots of hemosiderin accumulation inside the macrophagia, right? Heart failure cells, right? One more thing, if I give the same history, I'm having hemosiderin deposit in the lung, but as a fiber. Which fiber or which pneumoconiosis will have the hemosiderin fiber? One has one more name, ferruginous body. Which is that? Asbestosis, right? So asbestos will also have that. So the asbestos or the ferruginous body will have the same thing, against an iron getting deposited over the asbestos fiber, right? It's all iron. Brown color in microscopy, do a Pearl's Prussian blue, it will be positive, right? Copper. Copper, again brown in color. You must have seen copper vessels and copper utensils, right? What's the stain for copper? I can either use a stain called rhodamine, or we have any other stain for copper, rhodamine or rhodanine. The spelling both are one and the same. One is the procedure, other is the stain, right? And we have a stain called Orcine. Orcine stain is something which is much easier for a pathologist, but if you remember rhodamine, more than enough. What disease? Copper excess. We have one disease. What's your Wilson's disease, right? Your hepatolenticular degeneration, your KF ring. I'm sure you must have seen or must have been shown in ophthalmic sessions. The KF ring is a classical finding, right? And you can have the basal ganglia involvement and everything, fine, perfect. Carbon will be black, right? So diagnosis, the only thing in microscopy which will be black in color is carbon. Rest every pigment is brown in color in microscopy. Nothing else will be black. There's one more place will be black, I'll tell you. Carbon will be seen in anthracosis, coal workers pneumoconiosis, like in our case, fine. Carbon does not require any other stain, right? There's one more place where I can have a black pigment in liver. Liver having a black pigment. Any clues? And I'll have one more question as well. Not so direct. Skin having black pigmentation. These are primarily for MCQs. You might not see these cases. Liver having black pigment. Have you heard about a condition called as Dubin-Johnson syndrome? Dubin-Johnson syndrome is a congenital syndrome which produces jaundice. It will have a black color pigment in the liver, right? Skin having black pigment, or tongue or lips having black pigment. Have you read that a drug called as minocycline causes pigmentation? Minocycline induced pigmentation are black in color in a skin biopsy, right? So that's a drug side effect, and you have the Dubin-Johnson syndrome. These are the only black pigments you can see, but rest everything are brown pigments only, right? So again, this is a good table for you to quickly revise all the pigments required for us, fine? Okay, next. CD95 is a marker of. It's a very simple thing. Apoptosis, necrosis, I'm not going to spend time because I'm sure that this is the only thing you keep on revising every time. Rahul, let's start with A, B. Okay. How did we make mistakes in apoptosis and necrosis? You should not make mistakes in apoptosis and necrosis. Others, what do you think is the answer? CD95 is a marker of. CD95's other name is, it's one of the TNF receptors family, right? It's a TNF receptor family, or the FAS receptors other name is CD95. It's involved in the extrinsic pathway of apoptosis. Intrinsic, right? Intrinsic is cell inside the cell, which is mitochondrial mediated. This extrinsic is a receptor on the cell membrane. This is cell membrane mediated. Fine. Okay. Just since we are in the topic of apoptosis, let's have a quick call on in general about apoptosis. See, you guys all will clear FMGE. Don't worry about that. That is not the goal at all. Our goal is to become amazing doctors, right? It's to understand medicine. Because once you understand medicine, MCQs are nothing in front of you. If I have a chance to meet any of you 10 years down the road, I'll ask you which is the easiest time of your life. You will say FMG prep and EPG prep. That is undoubtedly the easiest time of your life. Once you go outside, patient is not going to come and say, doctor, 4 options, diagnose something. Enjoy medicine. Once you start enjoying medicine, you will learn that, okay, this is very simple. Why did I break my head? Apoptosis, it's not apoptosis. It's apoptosis. Now it makes lots of sense. What does ptosis mean? What do you mean by ptosis? You must have read in your ophthalm. Drooping of eyelid, right? Apo means precursor. It's before dropping. Apoptosis means the exact mechanism which happens before cell death. And this mechanism is extremely programmed. That's why we call it a programmed cell death. It's perfectly followed, one via extrinsic pathway, one via intrinsic pathway. It follows a very classical template. That's why we call it apoptosis, and it's a physiological form of cell death. Fine. Now, what is the other type of cell death? I'm sure you know that. Necrosis is one, apoptosis is one, right? We'll just have a quick out of the box thinking, and then we'll obviously go to the things as well. Fine. Okay. Now, if you have a look at this, tell me which will have cell membrane damage, apoptosis, necrosis. I'm writing CM for cell membrane, will obviously be damaged in necrosis, right? It'll be intact in case of apoptosis, right? Perfect. Second thing, if cell membrane is damaged in necrosis, can I say intracellular contents can come outside? Obviously. That's why you use troponin for a myocardial infarction. Troponin is an intracellular content of cardiac myocyte. So once it's having infarction, troponin becomes more in the blood. That's why I use SGOT, SGPT, AST, ALT levels for liver injury. Because AST, ALT is seen in liver. Once liver is dead, it comes to the blood supply. That's all, right? In other words, once it's damaged, will it have inflammation? Yes or no? Present or not present? Cells are going, contents are going outside. Inflammation by default will be present, right? If inflammation is present and in apoptosis, it's intact cell membrane, nothing leaks outside, will there be inflammation? There'll be no inflammation, right? Okay. Right? We just need to remember this. We can extrapolate many things from that, right? If I'm having inflammation in a process of cell death, will the patient have pain? Will pain be there? Will there be pain or no pain? Undoubtedly pain will be there, because pain, one of the classical hallmark of inflammation is rubor, calor, tumor, dolor, and loss of function, right? Dolor means pain. Your dolor 650 name came from dolor, right? It's dolor means pain, right? It's pain. So patient will have pain. So tell me which of these two types of cell death can be physiological. Physiological should not pain. Pathological can pain, right? Physiological should not pain. Apoptosis can be both physiological and pathological. Necrosis can never be physiological. It is always pathological. Okay. I'll ask you a different question. Which of these two types of cell death is good for the patient? Necrosis or apoptosis? Which you think is good? Tell me anyone. 50% you have the right answer. Which is good, necrosis or apoptosis? Most of you will think that apoptosis is good, right? Apoptosis is bad. Necrosis is good because necrosis will have pain. If there is a pain or inflammation, the patient comes to a doctor. When the patient comes to a doctor, I will diagnose the disease, I will treat the disease. Apoptosis, when it's pathological, I'm not talking about physiological thing. When it's pathological, apoptosis will not have pain. There's no pain, no symptom. Patient will not come to a doctor, right? That's why mutation cell dies by apoptosis. Unfortunate. I will not be able to diagnose tumors or cancers, right? Protein misfolding defects by apoptosis. Parkinson's, Alzheimer's, Prion's disease, apoptosis. I cannot diagnose them early. It will by default be diagnosed late only because it's by apoptosis, right? These are problems of apoptosis. But yes, apoptosis to some extent is definitely bad if it's pathological. Physiological, it's good, right? So DNA damage, protein denaturation, everything will go via the intrinsic pathway of apoptosis, which happens via the mitochondria, where you have multiple factors or the genes or proteins, BCL2 family of proteins, right? Remember, pro-apoptotic and anti-apoptotic, if it's BCL2, anything with L gives long life. If it's long life, it's anti-apoptotic. Only when it's anti-apoptotic, the life will be longer. Just a clue to remember, BCL2, BCLXL, BCL, MCL1, everything with L is a longer life. An exception of this is BCLXS. Maybe remember S, right? It's short. This is pro-apoptotic. Fine. Rest everything with L is an anti-apoptotic gene only. Fine. Based on the anti-apoptotic gene, the entire caspases will be activated, which will destroy the cell into multiple things. At the same time, FAS ligand, this CD95 was a question, right? That's the other name for FAS. CD95 triggers via virus. Virus triggers the extrinsic pathway of apoptosis. That's how most of the cell death will happen, right? That's the very tiny part, but virus will always trigger the extrinsic pathway of apoptosis, right? Okay, so the next question. Simple question. This you must have read from your second year of MBBS, from your college days. One thing which you are never worry about it. Liquefactor necrosis typically seen in, it's not a difficult thing at all, right? It's seen in ischemic necrosis of the brain, right? That's a very classical and a very, very simple statement, right? Few words about necrosis, the types of necrosis, right? Coagulated necrosis, infarct of any solid organ is coagulated necrosis. Infarct of brain is liquefactor necrosis, right? Coagulated necrosis is seen in case of dry gangrene. Dry gangrene is a gross finding for cell death. If my finger is dead, black in color, we call it gangrene, right? Liquefactor necrosis, apart from the seen as infarct, it can also be seen in acute pancreatitis. Okay, put a star mark here because you will get confused. Acute pancreatitis is always liquefactor necrosis, not fat necrosis. I'll tell you why very, very soon. Fine, put a star mark. And also an abscess cavity. Whenever there's an abscess cavity, you will end up in having liquefactor necrosis. Mechanism of coagulated necrosis, protein degradation or protein denaturation. Mechanism of liquefactor necrosis, enzyme activation. Right? That's the biggest change here, right? One is enzyme activation, one is protein degradation, right? Now let's try to explain why brain dies by liquefactor necrosis, right? Have you touched brain? Anatomy, dissection hall. Have you touched brain? No. If you touched brain, brain is a very, very, very soft organ because brain parenchyma is predominantly made of fat. It's predominantly almost completely made of fat, right? Can protein degradation destroy fat? It cannot. That's why I need lipase activation or enzyme activation. I need lipase to be there for me to destroy fat because protein degradation cannot destroy fat, right? Doesn't mean that if you eat fat-rich foods like KFC chicken, brain will grow. Brain grows on only one fat, omega-3, omega-6 fatty acid. If you remember biochemistry, essential fatty acid, right? Brain grows only with omega-3, omega-6 fatty acid. How many of you have taken fish tablets? The yellow green tablets which you eat which smells bad. Whenever you burp, you'll have the smell of the fish. You've had it? It's been sold to many people saying that memory power will increase. Omega-3, omega-6 fatty acid. Fish is a very good source of omega-3, omega-6 fatty acid, right? Because that's required for brain parenchymal growth. Fine? Not yet. Don't eat shri. It'll not work now because brain will stop growing after 2 years of life. We know that. It does not grow. Till 2 years of life, brain grows beautifully. Next interesting question. If brain grows till 2 years of life, no kid is going to eat at 4 months, 6 months fish. Very less. Tell me one richest source of omega-3 fatty acid at 2-3 years of life or less than that. The richest source of omega-3, omega-6 fatty acid at birth, 1 month, 2 months. That is breast milk. That's why exclusive breastfeeding is very important. That's the only source of omega-3, omega-6 fatty acid which a kid can get at birth till 2 years of life. If you look at every pediatric textbook, they will say 6 months exclusive breastfeeding, 2 years optional breastfeeding, because till 2 years brain grows, right? So breast milk is very important. Next time when you're going to convince a mother to feed them, tell the mother, give breastfeeding properly, your kid will get first rank in school. You know our parents, right? They'll breastfeed for next 5-10 years, right? That's what happened. But after 2 years or after 5 years, they'll come back and say kid is not performing well in school. That time tell mark is not equivalent to brain development. Tape recorder will pass FMGE, NEET PG, INICT, USMLE, BLAB better than all of us. Right? ChatGPT will do better. Doesn't mean that it's intelligent, right? Our goal is different. This is a passing cloud. You will definitely clear it, right? Microscopy of coagulated necrosis. The architecture will be maintained, and here the architecture will be lost. Why architecture is lost is brain is becoming liquid. Obviously, brain is not brain. It's completely been destroyed. It's been lost. That's why in microscopy, I won't have architecture, right? Okay. This came in a NEET PG exam. Tell me what structure is this? The structure came in a histology question in NEET PG. What structure is that? Can anyone tell me that? The circled one? That's a glomerulus. That's a glomerulus. That's how a glomerulus looks like. Fine. Okay. One more question before going to the next next identification here. We did discuss that nucleus will be blue in color. In a dead cell, the nucleus will be present. It will not be present. Necrosis is dead cell. Will there be nucleus? No nucleus. There won't be any nucleus, right? Now, what are these structures? What are these structures? It's very close to a glomeruli. Can I call it a tubule? Yes, a tubule, right? Now, look at this tubule. Is there any nucleus in the tubule, or it's completely pink in color? It's completely pink in color, right? There's a tubule which is dead, right? So this is what happens in case of an acute tubular necrosis, right? And even if it's dead tubule, it is looking like a tubule. That's what architecture being maintained is, fine? That's a classical example of coagulated necrosis, right? Let's go to the next one. We know about coagulated liquefactor, caseous. Caseous is cheese-like. It's caseous necrosis. What's the diagnosis? Only one guy, TB. By default, it has to be TB. Whichever part of the world you are, caseous necrosis means first thing and the only diagnosis as an undergraduate, I want you to think of tuberculosis, fine? Okay. Fibrinoid. Oid is equivalent to like. Oid means like lymphoid, lymphocyte-like, myeloid, myelocyte-like, colloid, collagen-like, right? Thyroid, shield-like, right? That's oid means like, that's all, right? Rahul, you're right in calling pan. That was a PYQ. Let's not read PYQ. Let's read the entire thing, right? It's fibrinoid necrosis, which means it is fibrin-like necrosis. Where do you see fibrin? In which condition fibrinogen will be converted to fibrin? There's only one place in the body where fibrinogen becomes fibrin or fibrin, whatever you call it. Blood clot. Perfect. So can I say every vessel wall damage will have fibrin-like material or fibrin-like necrosis? You will, right? So fibrin-like necrosis will be seen in every vessel wall damage. Rahul, now a question back to you. Will it be seen only in pan or any vasculitis? Only pan or any vasculitis? Any vasculitis. So next time when I ask a PYQ with option of not having pan but having Takayasu arthritis, answer is right. Kawasaki disease, answer is right. Temporal arthritis, answer is right. Pan also is right, right? When you have a vessel wall damage, I'll have a fibrin-like necrosis because fibrin is seen in vessel wall damage. That's all, right? So you can see them in any vasculitis. Can I see them in SLE? SLE is also a type of vasculitis, right? I'll give you one more question. Flea-bitten kidney. Which disease you see flea-bitten appearance of flea-bitten kidney? You know the answer. Flea-bitten kidney. Which disease? Malignant hypertension, right? Perfect. In malignant hypertension also I have this because in malignant hypertension the BP is somewhere in 200 millimeter mercury. Vessel will rupture. Vessel wall damage, fibrinoid necrosis. Ash of bodies, where do you see it? Ash of bodies. Rheumatic heart disease, right? In ash of bodies also I will see fibrinoid necrosis because heart is considered to be the biggest vessel. Vessel as endocardium, heart as endocardium, myocardium, pericardium. Vessel as tunica intima, tunica media, tunica adventitia. Same, right? So heart is considered to be the biggest vessel, so it will have that, fine. Last but not least, fat necrosis. Fat necrosis I can see due to trauma in breast parenchyma, in the gluteal region, all these areas where you have lots of fat, you can have trauma-induced fat necrosis, and then I can have it in peripancreatic fat, or I can have it in omentum, okay, due to liquefactor necrosis, due to pancreatitis. Okay, this is very careful. What's the type of necrosis in pancreatitis? Pancreatitis causes liquefactor necrosis, right? So patient has pancreatitis. Can I say the mechanism of pancreatitis is activation of trypsin, chymotrypsin and everything? Lipase, right? So pancreatic enzymes will be activated. It will go outside the pancreas or to the omentum and destroys the omental fat. Pancreas, I'll have liquefactor necrosis. Surrounding the pancreas, the fat will type a fat necrosis, right? Please be very careful when the question is being asked on that, fine? Okay, next, Psammoma body. That's also a very simple question. Psammoma body, what's the answer? Whatever comes to your mind. Answer is A, right? I am 100% sure you know the mnemonic of PSM squared, right? I'm not going with mnemonic. If mnemonic helps you, go with the mnemonic. I go with logic because logic is much more comfortable for me to remember than mnemonic, right? What's the first tumor which comes to your mind when you think of Psammoma body? Papillary carcinoma thyroid, right? That's what everyone remembers first. Dr. Sri, it's all except. I think you didn't read the all except, right? So Psammoma body, everyone thinks of a papillary carcinoma thyroid, right? That's the first thing which comes to your mind. So papillae means you have a finger-like projection with a central vessel. That's your papillae. That's papillae mean, right? I'm having a finger-like structure with a central vessel is papillae. Fine. Now tell me the tip of the papillae, right? This tip will have less blood supply, more blood supply. Tip of the papillae by default will have less blood supply. With this less blood supply, can there be a chance of necrosis, infarction necrosis? Yes. What's the most common ion in irreversible cell injury? Sodium or calcium? Irreversible cell injury. Calcium, right? So by default, the most common ion is calcium. So there'll be excess calcium here. So over a long period of time, can it cause calcification? It can. That is Psammoma bodies. So Psammoma body is due to papillae. So now tell me, is it seen only in papillary carcinoma thyroid or in any cancer which has papillae? Any cancer with papillae, right? Papillary carcinoma breast, papillary carcinoma kidney, yes, right? So any cancer which is papillae will have Psammoma bodies. That's all, right? So tumors where Psammoma bodies are seen There are two things I want you to remember. Tumors with papillae in the name. If the tumor has papillary in name, the tumor will have Psammoma bodies by default. Tumors with serous in the name. Serous tumors in microscopy will have papillae. Serous is studied in custom of ovary, endometrium, omentum, pancreas, everywhere. Everywhere will have it. It's not PSM squared alone. PSM squared helps you to remember only papillary carcinoma thyroid. If I have changed the question, papillary carcinoma of breast, answer is same. It will cause it. Any papillary tumor, not just serous tumor of ovary, omentum, pancreas, lung, right? Mesotheliomas, papillary mesothelioma, serous mesothelioma will have it, right? Anything with papillae, anything with serous will have it, right? That's one. Second, meningioma. Meningioma has something called an world appearance, right? This appearance called an world. Same concept. The center of the world will have less blood supply. Less blood supply will have necrosis. Necrosis will have more calcium. More calcium will have same Psammoma, right? So the thing is, tumors which have world appearance, two tumors. One is meningioma. The other is leiomyoma. Both of them will have Psammoma bodies, right? This is a concept-based learning. It's much comfortable. My only concern with the PSM squared is it will help you to solve PYQs. Will it help you to solve any other questions in the same topic? Might be a bit difficult. Because when I prepared for entrance, it was only PSM. After that, prolactinoma came in an exam. Only one exam. Because prolactinomas, only 10% of them have Psammoma bodies. Stomatostatinoma came in the second exam. INACT. Very rare questions come only once. Don't remember that. Not required. It will not be repeated at all. If it's repeated anyway, you know the PSM square, right? Okay. So that's how you remember. But the unfortunate thing about the mnemonic is, does leiomyoma come in the mnemonic of PSM square? It does not, right? Dr. Oshika took the OBG class. Can I say uterus fibroid, calcific degeneration is one of the commonest degeneration? It is one of the commonest degeneration, right? So something what I'm learning in this time is not letting me remember the common things. Of all the tumors, the commonest tumor is fibroid. And fibroid will have Psammoma body. But this is not teaching me that, right? So let's go with concepts. Goal is not to clear the exam. You will undoubtedly clear the exam. Goal is for a very, very, very long term. Fine. Okay. Let's go to next question. Very simple question. We'll not discuss much about this. Predisposing factor for skin cancer. B, right? UV light by default is one of the most important predisposing factor of skin cancer. Smoking might not. Chronic ulcer, I might put to some extent. Here, if I want, I will say B is more important than C, right? Chronic ulcer, yes, to some extent can result in cancer. Not just an ulcer. It could be an burn-related cancer. Have you heard about Marjolin's ulcer in your surgery? You might have heard about Marjolin's ulcer, right? So if it's a multiple choice option, I would put UV light and then chronic ulcer. Infrared and smoking will not contribute to skin cancer, right? There's a type of an ulcer called as Marjolin's ulcer, right? Marjolin's ulcer is squamous cell carcinoma post burns. Okay, that's obviously skin cancer, burn related. Okay, again, very rarely few ulcers can also result in cancer. Not diabetic foot ulcer will not cause cancer. That ulcer will not, but few ulcers can definitely cause cancer. But the best option obviously here is option B, right? Okay. Next. Let's spend little bit time to understand this. Answer. Reversible loss of polarity is in cell and shape is known as, okay, the tree is gone with B and Kaushik is gone with B. Dysplasia, right? Okay, next question. Is dysplasia reversible or not reversible? Dysplasia, reversible, not reversible? It is reversible, right? It is reversible as well as irreversible. We'll look at that very soon, right? It can be reversible as well as irreversible, fine. Okay, perfect. So now there are 4 features which I want you to remember for any cancer in microscopy, fine? Any cancer in microscopy, I want you to remember these 4 features. Microscopy, fine? Okay. What does hyperplasia means? Increase in cell number. Metaplasia means change in one cell type to another cell type. Anaplasia is very, very worst, right? There's a very worst kind of dysplasia or a very high grade dysplasia, which is irreversible. Okay, it's irreversible. So that's why we are ignoring that for this question, right? Now, the four features. These are the four features which I want to remember: pleomorphism, high NC ratio, mitosis, and loss of polarity. Pleomorphism, as the name says, multiple morphology, or in other words, variation in size and shape. The size and shape is abnormally varied. I call it a pleomorphic condition. High NC ratio, more nucleus to cytoplasm, right? Let's assume there's a neutrophil. When it becomes a cancer, it becomes a blast. You must have heard about myeloblast. Can I say by default myeloblast will have good amount of nucleus? Very high quantity of nucleus will have. That's high NC ratio, right? Which means more nuclear characters. That's all. Mitosis, fine. It's my favorite thing. What are the phases of mitosis? Anyone? The phases of mitosis. Do you remember that? You might have remembered, might have not. Prophase, metaphase, anaphase, telophase. Does it ring a bell? You must have definitely remembered, right? Prophase, metaphase, anaphase, telophase. Perfect. Amazing, Sri. How many of you remember that? Most of you listening will remember this. When did you read prophase, metaphase, anaphase, telophase? During MBBS or during school? Biology. When have you read prophase, metaphase, anaphase, telophase? School days, right? Still remember that? If you remember that, tell to yourselves, your memory is good. We always keep telling excuses, saying that I read, I forgot. We always keep saying this excuse, right? I read, I forgot. If you can remember prophase, metaphase, anaphase, telophase, which you read in school, which means in college you didn't read. Let's understand that. Let's accept that. I didn't read well, so I'm not remembering it. Now, in 6 months, I'm rushing things, so I'm forgetting things. Don't blame your brain. Your brain is amazing. It's very, very, very superb organ. Feed it good thing, it'll give the output good, right? So your brain is good, your memory is good. All of your memory will fall in the same thing only. Some are extra super intelligent. Don't worry, they won't become doctors. They'll be doing something else, right? So all your memory is very, very good. If you read, you will remember. Spend time, you will definitely remember, right? Let's come back to mitosis. Either I should have an increase in mitosis or an abnormal mitosis. Okay. Normally mitosis, if you remember the prophase, anaphase, metaphase, telophase, at the telophase, one cell will divide, the chromatin will go to the corner, mitotic spindles, and becomes two new cells. If abnormal mitosis is nothing but, if anything is more than 2, it's abnormal. Normally, we'll give us only 2 new cells. Abnormal is others, right? Loss of polarity, we'll look at with few examples, fine? Now, can I say this is a mitotic cell dividing into 2 directions? Dividing in 3 different directions, abnormal mitosis. Dividing in 5 different directions, abnormal mitosis, right? So these 2 are abnormal mitosis. The first one is a normal mitotic figure dividing in 2 different directions, right? That's how an abnormal mitotic figure looks, right? Now let's understand what does loss of polarity mean. What is the structure? What is the histology? You guys identified glomerulus, so this is a piece of cake. What histology is this? That's a skin, right? Stratified squamous epithelium, that's a skin biopsy, okay? What is the lowermost layer of skin? We call it a stratum germinatum. We call this stratum corneum. If you remember your dermatology classes, stratum corneum, do they have nucleus or no nucleus? Stratum corneum is generally anucleate, right? Stratum corneum has the pinkish color, anucleate cells, right? So in other words, when a cell moves from stratum basale to stratum corneum, the normal polarity is it will lose its nuclei. That's normal for skin. Every top layer of skin should not have nuclei. If they have nuclei, I have a problem. In other words, if they have nuclei, I call it loss of polarity, right? This is a biopsy from an ulcer of skin, right? Now just tell me, this is my topmost layer. Do I have nucleus or not? Nucleus is blue color. Yes, no. I want you guys to answer yes or no. Definitely yes. Topmost layer is having nucleus, right? So can I say in this, let's take this part alone. There's pleomorphism, change in shape, size. Everything is not looking the same. Everything is a bit different, right? Perfect. Can I say this cell has a very big nucleus, a very big nucleus, very big nucleus? Yes. Perfect. Can anyone tell me what this is? Normal mitosis or abnormal mitosis? Looking like Christmas tree. Normal, abnormal. Abnormal mitosis, right? Perfect. So now this biopsy has pleomorphism, has high NC ratio, has mitosis, has loss of polarity because the topmost layer was having the nucleus, right? So this biopsy is a normal biopsy or an abnormal biopsy, or this growth, the ulcer or whatever growth it is, normal or abnormal. So this biopsy is nothing but an abnormal biopsy or an abnormal growth. Can I say that? I can definitely say that, right? What's a technical term given for abnormality? What does abnormal mean? Any of you from Russia or Ukraine? Here? Anyone did your MBBS from Russia or Ukraine? If you're done MBBS from Russia and Ukraine, and if you're not learning medicine, you're doing a crime. Because people who come from Russia and Ukraine, fortunately, they have Latin in their first year. You don't know your power. Latin is the base of medicine, right? If you're from Russia and Ukraine and you're not doing well in MBBS, you are just lazy. Okay, accept that. This means abnormal. Dysphagia, abnormal eating. Dyspnea, abnormal breathing. Dysmenorrhea, abnormal menstruation. Dyspareunia, abnormal sexual intercourse. Can be difficulty, can be pain. This is abnormal. So abnormal growth is dysplasia. This is dysplastic. When I have all the four features, I can call something as dysplastic, right? I have two things here. Dysplastic can be a low-grade dysplasia or a high-grade dysplasia. Okay. Low-grade dysplasia is always reversible. High-grade dysplasia obviously becomes irreversible. So dysplasia can be both reversible and irreversible. I'll give an example for us to understand this. Since OBG is over, did Dr. Oshika talk about cervix CAN1, 2 and CAN3? You must have read about CAN1, CAN2 and CAN3, right? CAN1 is low-grade dysplasia. Do you remove the uterus? You don't. CAN3 is high-grade dysplasia. I can remove the uterus because it's irreversible, right? Barrett's esophagus, low-grade dysplasia. Treatment is proton pump inhibitors. Medical management. Barrett's esophagus, high-grade dysplasia, surgical management. Because low-grade is reversible, I wait and watch, give some medicine. High-grade is irreversible, nothing will happen, I have to remove the organ. Treatment is based on the microscopy finding, right? That's how we always say one is reversible, other is irreversible, right? So now we know everything about dysplasia as well, right? Next. So the following you think is required for growth. Anything which comes across your mind. Right answer? A, B, C, D. A, right? Proto-oncogenes are the one which will help in required for normal growth, right? Now I have two things here. I have proto-oncogenes as well as I have oncogenes, right? So these are normal genes required for growth. Okay, oncogene is a mutated proto-oncogene. So oncogene is not normal. So the question is asking which is required for a normal growth. Answer cannot be oncogene because oncogene is not normal. It's a mutation, right? Tumor suppressor genes is actually the reverse. They will inhibit growth or they will suppress tumor formation. Tumor is nothing but uncontrolled division. This will stop the division or they are going to be antagonizing the growth of it. Fine. Okay. Perfect. Okay. Now let's have a quick look about few of the proto-oncogenes which might come in an exam. Fine. RAS is the most common proto-oncogene mutated. throughout the body. RAS is seen in case of your lung, colon, and pancreatic adenocarcinomas. Okay, all adenocarcinomas, not squamous. Only in adenocarcinomas I'll have this. Okay, all these, whatever proto-oncogene I'm going to tell you is important because it is useful for diagnosis or prognosis. Right? PRAF is seen in melanoma, a tumor called as hairy cell leukemia. Okay. EGFR is seen in lung adenocarcinomas. Okay. HER2/neu. Where do you see HER2/neu? You guys know the answer. HER2/neu is something which you read often. HER2/neu is seen in, it is seen in breast cancers. It's seen in breast cancers. Fine. JAK2. It's seen in polycythemia vera. This came in an exam. Polycythemia vera is a neoplasm of RBCs, right? Plasma RBCs where JAK2 is predominantly involved, right? ABL. You guys should know ABL. Where do you see ABL? I'll add one more term to it. It becomes much easier. BCR-ABL. Where do you see BCR-ABL? That's a common question. Or a translocation between 922. It's seen in chronic myeloid leukemia or a CML. That's a very common finding, right? BCR-ABL is seen in chronic myeloid leukemia. Rett proto-oncogene is a tumor seen in MEN2 syndrome. We have Rett mutations. At least remember two things here. One is medullary carcinoma thyroid. That's a common finding in MEN2 syndrome. And also one more thing, which is your pheochromocytoma. Okay. Pheochromocytoma is a tumor seen in adrenal gland. Right? It's an adrenal tumor. You will see that in the adrenal medulla. Fine. Okay, these are few proto-oncogenes which is required. All these proto-oncogenes are involved in the management of patients. Only things which are involved in the management we have to remember. Rest everything is not required for us to remember, right? These are something which is must to remember. Fine. Okay. Now let's have a quick look about something called tumor suppressor gene also. Okay. The normal function of tumor suppressor gene is to reduced cell division. They are tumor suppressor, right? So listen carefully and answer. If a tumor suppressor gene is mutated, it causes cancer, right? What mutation will cause cancer? Gain of function or loss of function? The mutation here should be gain of function or loss of function. What mutation will cause cancer? It is loss of function. Because only when the function is lost, normal function is to suppress cell division. The function is gone. I am not able to suppress cell division. More and more cell division happens, right? It has to be a loss of function mutation. Fine. Just one more question to learn one more concept. Let's say, how many copies of every gene do we have? If I take BCR-ABL, how many copies do we have? One copy or two copies? Two copies, right? Let's say that I have a tumor suppressor gene with two copies. One copy is lost. Will the other copy still function or it will not function? It will still function, right? Will it still stop tumor growth? It will still stop tumor growth, right? Now tell me, when will a person have cancer? When one is mutated or when both are mutated? When do you think a person will have cancer with tumor suppressor gene? It is 2. That is given by a famous hypothesis called as Knudsen 2-hit hypothesis. Okay, so Knudsen 2-hit hypothesis says that you need both copy to be mutated. Only then you will have cancer. Otherwise, it will not result in a cancer. Only when both the copies are mutated, you'll have a cancer, right? I'll have a subtle clue here. The clue is how to identify tumor suppressor. Most inherited cancer syndromes will be tumor suppressor. Most of them. One exception we already read, MEN syndrome. MEN syndrome is proto-oncogene. Most of the inherited cancer syndrome is tumor suppressor. Can you guys give any one example of an inherited cancer syndrome? Any one example, inherited cancer syndrome. You should remember. Surgery postings, surgery, you must have read about multiple colonic syndromes. At least one. Familial adenomatous polyposis, tumor suppressor. Cowden, tumor suppressor. HNPC, retinoblastoma, tumor suppressor. If it's an inherited cancer syndrome, tumor suppressor. Neurofibromatosis, tumor suppressor. Von Hippel-Lindau, tumor suppressor. All are inherited cancer syndromes, right? RB gene, like someone said, it's seen in retinoblastoma and also osteosarcoma. Fine. PIF3 is the most common mutated gene worldwide in cancers. It's also called as a guardian angel of genome. Once PIF3 is gone, everything is gone. It can result in sarcomas, leukemias, brain cancer, breast cancer. Almost every organ will be affected when PIF3 is gone, right? CDH1, it codes for a protein called an 𝐒𝐿. CDH1 is mutated in two cancers. One is lobular carcinoma of breast, not the ductal cancer, lobular cancer, and also your gastric carcinoma. One type of gastric carcinoma called as diffuse gastric carcinoma. You will have your 𝐒𝐿 CDH1 mutated. VHL, any one cancer with VHL mutation, any one cancer with VHL mutation is your clear cell RCC. Clear cell renal cell carcinoma with VHL. APC is nothing but your gene mutated in FAP, the colonic polyps. Familial adenomatous polyposis, colonic adenocarcinomas. STK11, which syndrome? Yes, you're right, Sri. STK11, which syndrome? Peutz-Jeghers syndrome. Okay. It's seen in Peutz-Jeghers syndrome as a classical thing, which also has colonic tumors and colonic polyps, right? Not just Peutz-Jeghers, right? This also will have colonic lesions, colonic tumors. In addition to colonic tumors, Peutz-Jeghers syndrome has one classical finding. You'll have oral hyperpigmentation. The lips and the surrounding area in the oral mucosa will have hyperpigmentation. That's also a classical finding in Peutz-Jeghers syndrome. Fine. Okay. A few things for tumor suppressor genes to remember. But remember, everything should have two mutations. Only then it will cause cancer. Right. Next question. It's a very simple question. What's your answer? Tell me whatever comes to your mind. Seek it for just, you are right. Which of the following is an intrinsic defect in the RBC membrane? Intrinsic means it's a defect in the membrane. Obviously, HS, right? It's not difficult to remember. Autoimmune hemolytic anemia is due to antibodies from outside. Microangiopathic hemolytic anemia, it's trauma, right? Your clot formation will destroy that. This is also from outside, right? Thermal injury, it's injury from outside, right? It's also outside. All these are extrinsic, right? All these are extrinsic defects. Dr. Sri, I think you're confusing CD55 and CD59. Can anyone tell me which disease has CD59 and 55 defect? Okay, rest everything is extrinsic defect. The only thing here defect is hereditary spherocytosis. Spherocytosis, you have a defect of spectrin, ankyrin, band 3 and band 4.2, right? Not in your 55-59. 55-59 will be seen in PNH. Okay, CD55, CD59 defect will be seen in case of a paroxysomal nocturnal hemoglobinuria. That's also a hemolytic anemia. In HS, you will have the most common mutation is ankyrin. Okay, you can have mutations in spectrin. Right, you can have, these are the most common mutations in ankyrin. If you remember that, that should be more than enough, right? So hereditary spherocytosis is an autosomal dominant disorder, autosomal dominant defect. Okay, and we look at spherocyte, how it looks like very soon, right? So intrinsic defect is only spherocytosis. It's a cell membrane of the RBC's defect. Okay. Okay, this is a question in NEET PG exam. Most of your seniors again fought on something which is irrelevant in this question. Tell me what's the right answer and let's discuss this question. What's the right answer? Okay, A, Rahul with A, Sri with A, Nitin with A. Okay, great. When this question came in an exam, most of your seniors said that. Some of them said that it's benzene. Some of them said it's benzidine. And so they are fighting. It's benzene or benzidine. Because benzene, right, causes leukemia. Benzidine causes bladder cancer. Right, perfect. So this was a confusion. So whenever there's a recall, no, if I have written bladder cancer in an exam, I will say it was benzidine. If I have written leukemia in exam, I will say it's benzene. So recall will always have its bias, right? The good thing about your FMG exam the last 2 years or three sessions is it is having lots of scenario based question. Tell me honestly, scenario based question is easy or difficult? What is your take? Close 10 people here. Tell me what's your take. Scenario based questions are easy or difficult? Whatever comes to your mind. Yes or no, that's all. Scenario based questions are actually very easy. One liners are actually very, very difficult because in a one liner, there's no clue. In a scenario, I have 3 lines. There will be some clue, right? So the only problem with scenario based question is if you're lazy and not able to read the 3 lines, develop the attitude. That's all. Because this question, I don't want memory here. Let's look at the history. Repeated infection, easy fatigability, weight loss, evening rise of temperature. This is due to reduced WBC. This is due to reduced hemoglobin, right? Easy rise of temperature also infection related. Tell me which of these 4 cancers will have the symptom? Only one, leukemia. This won't have the symptom. This won't have the symptom. This won't have the symptom. I don't want to you to memorize benzene or benzidine. Doesn't matter for me. I have a patient. If I have a patient, I look at the patient. Everything else surrounding the patient is irrelevant. This is how real life treats you. Scenario based questions are very, very easy. Even if the student has said it's benzidine, I will not think of a bladder cancer in this patient because bladder cancer cannot have repeated infections. Bladder cancer can have hematuria. That's a symptom, right? What do you think will be a symptom of lung cancer? Hemoptysis, skin cancer, ulcer or a growth. Pigmented, non-pigmented, right? History is more important, and if it's a scenario based question, it makes your life much easier. Don't worry, people scare you saying it's scenario based question, right? The reason is that's what they want. Don't be scared. It's an exam. It's 300 MCQs, right? You will solve it. You're much more powerful than 300 MCQs, right? Next question. Burst cells are seen in. This is difficult because if you don't know what is burst cell, you can't write the answer. Right? Burst cells are classical findings seen in case of an uremia or CKD. Burst cells other name is an echinocyte, where this may normal RBC, it becomes like this. It becomes like a spike. That's a burst cell or an echino. It looks like a porcupine. Sea porcupines are called echen. So echinocytes, it looks like that. Fine. Okay, let's look at few images which might come in an exam. What cell is this? Quickly, that's an target cell, right? So these are few cells. I'm sure you must have identified target cell, but the other name for target cell is podocytes. See, because if you start reading more and more, I can't start asking you simple questions, right? I will have to increase the level. So I use the other name, podocytes. RBC, erythrocyte. Like that, I have sites for every cell, right? I can see that in thalassemia, like she said, sometimes in sickle, very rarely, very severe iron deficiency anemia also. Very severe IDA also, I can have it. But first diagnosis, thalassemia, fine? Okay, this one here, the spikes here are regular or irregular on the RBC. They are irregular spikes. So we call it an acanthocyte or a spur cell. Spur cell is different from a burst cell, right? These are irregular projections. Okay, they are irregular projections. Rahul, I'll show you burst cell also. Okay, this is burst cell. Burst cell or echinocytes will have regular projections. The projections will be very regular. Okay, and this is seen in CKD or uremia. This is burst cells. I hope you can appreciate this difference between this and this. This is not regular. It is definitely irregular projections. So we call it an acanthocyte, right? And like Dr. Sri said, A beta lipoproteinemia has come in an exam, but I want you to first think of liver failure. Once liver fails, you will have acanthocytes. That's the common thing. And obviously A beta lipoproteinemia, right? Don't memorize. Once you memorize, no, it's very difficult for us to recollect after 10 years. I'm reading. Let's read for 10, 20 years. Why to read for 6 months, right? A beta lipoproteinemia. What does it mean? What do you mean by A beta lipoproteinemia? There is no beta lipoprotein, right? That's what it means. A absent beta lipoprotein, right? If the beta lipoprotein is not there, will the cell membrane be normal, abnormal? Because cell membrane is made of phospholipid bilayer. It will be abnormal. So when I don't have beta lipoprotein, the cell membrane is supposed to be like this, goes like this. That's what happens here. So now look at the first option. Can I say liver is the one which metabolizes every phospholipid? That's all. So if liver fails, phospholipid LDL, VLDL, HDL cannot be formed properly. My membrane cannot be normal. It goes like an irregular projection. We call it an acanthocyte, right? That's how it is. It causes it, fine. Next, simple spotter. Diagnosis, sickle cell, or there's one more name, drepanocytes. Drepano means like a boat. It looks like a boat. Sickle cell, seen in sickle cell anemia, right? It's not difficult here. Drepanocyte, perfect. What cell is this? Anyone? Any call? How does it look like? It's a very easy finding. It's a teardrop cell, right? It's a teardrop cell. Tear film, the other name is dacro, right? It's a dacrocyte. It's a tear. It looks like a teardrop, right? Teardrop cells are seen in condition called myelofibrosis. Again, it's a simple logic. If my bone marrow is completely fibrous, lots and lots of fibers, can an RBC easily come outside, or it should squeeze and come outside? It goes, squeezes, and comes outside like a teardrop. It's fibrotic bone marrow, right? That's why you have in myelofibrosis teardrop cells, okay? And we already saw your burst cells or your echinocytes in CKD. This is a broken RBC, right? It's very, very irregular. We call it schistiocyte or a fragmented cell. We see schistiocyte or fragmented cell in microangiopathic hemolytic anemia, your TTP, HUS. Have you heard these terms? Thrombotic thrombocytopenic purpura, hemolytic uremic syndrome. In all these conditions, we'll see schistiocytes or your fragmented RBCs. Fine? Clear? Great. Okay, perfect. There's a few microscopic findings here, right? Next question. Iron deficiency anemia. Which of the following is increased? What's your answer? A, B, C, or D? Or Sri with A, Rahul with A, Nitin with A. Perfect. Have you memorized this iron table? It's very difficult to memorize, right? Because it keeps on, memory is not so easy to memorize so many informations, right? 19 subjects. It's very, very difficult to remember 19 subjects, right? I'll give you an easy analogy to remember all the iron profile, fine? Okay. Iron profile, I have 4 things. I have serum iron, right? You have your transference saturation. Most of the time, these 4 only will happen in most of the iron profile, right? You have your serum ferritin. You have your total iron binding capacity. I'm rephrasing the total iron binding capacity as affinity to bind with iron. It's affinity to bind iron. Okay, that's what iron binding capacity is. Fine. Okay. Now let's see. Let's give an have an analogy to understand this. Okay. What is the function of transferrin? Transports iron to bone marrow. That's the function of transferrin, right? Now let's say if my serum iron is more, will transferrin be more bound with to iron or less bound? What will happen? When the iron is more, Binding will be more or less? Binding will obviously be more, right? Let's imagine you are sitting in a room, right? Let's say there are 10 chairs and there are 10 iron molecules coming. All the 10 iron molecules will sit in all the 10 chairs. Let's say if 20 iron molecules come, I won't have enough space. If only 2 iron molecules come, 8 will be empty. That's what saturation is, right? So in other words, serum iron and transference saturation is always directly proportional. What do I mean by directly proportional? If one increases, other will increase. If one decreases, other will decrease. Don't memorize. This is how it happens, right? Next is ferritin. Can I say ferritin is storage? Is a storage form of iron, right? And TABC is what I said, affinity, right? Let's imagine like this. You must have had your lunch, right? Now it's 2-3 hours after lunch. If I give you some food, will you eat? Affinity is more. When the stomach stores come down, when I'm hunger, my affinity is more. I don't give you food for 2 days. Hostel food also you'll eat full plate because affinity is more. But if you just now had your lunch, right now only you are having a lunch or tea, samosa, something you're having. If I give you more food, your affinity will be less for a normal human being, right? So in other words, when my storage of ferritin is more, what happens to TABC? Less or more? Storage is more, affinity is less. In other words, these both are inversely proportional. Okay, don't forget this, right? If the storage is more, affinity is less. If the storage is less, affinity is more by default, right? Now just remember these two. Then now let's come to diseases, because it makes very easy here. There are two diseases where iron profile is must. One is IDA, other is anemia of chronic disease. These are the only two diseases which is very, very essential. In other diseases, it's not that essential, fine? Okay, what do you think will happen to iron deficiency anemias? Iron, the name says it is less. Then if that is less, what is happening to transference saturation? By default less. What will happen to ferritin? Storage from an IDA, less or more? By default less. If ferritin is less, what will happen to TABC? It will be more. Don't memorize. It will take 20 seconds for you to recreate this in your mind. In an exam hall, you can use it beautifully. Don't memorize. 20 seconds is fine for me. You have close to a minute for a question, right? Approximately. Few are very simple, few might be difficult. That's more than enough, fine? Sachin, I am not the right person to talk about that, but looking at the scale of mental health disorders, you will undoubtedly have jobs. Okay, fine. So anemia of chronic disease, chronic disorder, right? Anemia of chronic disorder. Serum ferritin, can I say it's an acute phase reactant? When COVID was there, did we do ferritin for almost every people affected by COVID? We did do, right? So what do you think will happen to ferritin in case of anemia of chronic disease? More or less? It'll be more, right? So we'll start with this. Ferritin is an acute phase reactant. So when there's a chronic inflammation, ferritin becomes more. When ferritin becomes more, TABC less. When ferritin is more, right? When ferritin is more, that means my storage iron is more. So what will happen to the free iron? I'm storing more and more and more iron. So what will happen to the free iron? By default, less. When free iron is less, saturation is less. Okay, don't memorize. It's very simple. Remember, ferritin and your TABC are inversely proportional. Iron and transference saturation are always directly proportional. It makes our life much easier. Whatever disease you want to learn, use the same formula. You will definitely make no mistakes. Fine. Okay, let's go to the next one. It's a simple one-liner. Reticulocytes are stained with it's new methylene blue is the stain for reticulocytes, right? We have two stains in RBCs. One stain is Leishman stain. Leishman is the normal stain done for every peripheral smear, what you see. And new methylene blue, perfect. Like Atul said, it's a supravital stain. Okay, supravital stain, and it's done for reticulocytes. Okay, it's done for reticulocytes. Whenever I ask a simple question, many of you guys are commenting. I want everyone to comment when the question is a little bit difficult also. What will maximum happen? Am I going to give you a FMGE degree? No, I'm not that much worth it, right? So don't worry. If it's an error, make an error here so that your main exam you won't have errors, fine? Okay, there are only two stains we have for RBC. One is Leishman, one is new methylene blue, fine? Okay, next, Howell-Jolly bodies. Where do you see Howell-Jolly bodies? We have a simple way to remember all the inclusion bodies also. Don't worry about it. Howell-Jolly bodies are seen in answer. Okay, Rahul has gone with D. Anyone else? A, B, C, or D? It's D, right? Post-splenectomy, right? Let's try to remember all these inclusions. Like I said, I have two stains in RBC disorders. One is Leishman, one is new methylene blue. New methylene blue, the stain looks blue in color. That's why we have the name blue. Leishman, the stain looks like a normal PS, reddish in color, right? So don't make a mistake there, right? So once you know whether it's Leishman or a new methylene blue, it's very, very simple to identify inclusion bodies. Let's say it's a Leishman stain. A Leishman stain, the RBCs will be red in color. And if I have a single inclusion in a Leishman stain, which means the RBC is going to look like this. Every inclusion will be bluish in color. A tiny dot inside the RBC. I'm going to think of a Howell-Jolly bodies, right? If I have multiple inclusions, I have two possibilities, where the multiple inclusion is uniform like this throughout, or if the multiple inclusion is non-uniform towards a corner. It's uniform inclusion throughout or not uniform. If it's a uniform inclusion, I call it an basophilic stippling. It's stippled RBCs or basophilic stippling. Non-uniform, I use the term Pappenheimer bodies. Okay, Pappenheimer bodies are seen in sideroblastic anemia. Basophilic stippling will look very seen very soon. Right? It's simple. Just remember the inclusion color. That's all. Tiny one dot Howell-Jolly in a Leishman stain, because this is very, very important. New methylene blue, I'm going to use the same thing. Single inclusion, multiple uniform, multiple not uniform, right? Next, when you go with a new methylene blue, again, it'll be bluish in color RBCs. That's a clue. Never make a mistake here. If it's a single inclusion in a new methylene blue, it'll be like this tiny dot. We call this an Heinz bodies. Can anyone tell me where do you see Heinz body? Heinz body is seen in? Know the answer. Heinz body is seen in G6PD deficiency. Right, perfect. It's in G6PD deficiency. Blue color, single inclusion, right? Same, if it's multiple inclusions, again I go with the same concept. Is it multiple and uniform, or is it multiple and irregular, not uniform? If it's multiple and uniform, I call this an golf ball inclusion. Golf ball inclusions are seen in alpha thalassemias in a condition called as an HPH disease. Okay, it's HPH or alpha thalassemia, HPH disease. This is a normal reticulocyte. A normal reticulocyte also will have inclusions, bluish inclusions in new methylene blue, but they are irregular, not uniform. Fine. Okay, these are the 6 inclusions which can come in an exam. I'll show you every image now. I want you to just remember, first tell to yourselves Leishman or new methylene blue. If it's Leishman, single or multiple. If it's multiple, uniform or not uniform. Again, this can come handy. Read this the day before exam. If it comes in exam, vomit and get out of it. Be happy. Fine. Okay. Leishman, new methylene blue. New methylene blue. Right. Blue RBCs. Single, multiple. Multiple. Uniform, not uniform. Uniform. Diagnosis. What do you think is the diagnosis? It is perfect. It's your golf ball inclusion seen in your HBH or alpha thalassemia. Fine. It's very simple if you go with a routine template, right? Next, Leishman, new methylene blue. Leishman. I hope you can identify the difference. You won't make a mistake here, right? Leishman, multiple inclusion, multiple uniform inclusion, which is basophilic stippling. Perfect, right? So basophilic stippling will happen in any conditions when the nucleus is not normal. This can happen in MDS. This can happen in leukemia. Again, I have a problem with the nucleus. This can happen with drugs, especially chemotherapy drugs, which interfere with the cell's nucleus. It also can happen in megaloblastic anemia. Again, a problem with the nucleus. Megaloblastic. It also is a nuclear problem, right? So whenever you have a nuclear defect, I'll have basophilic stippling. Lead poisoning again. Again, a problem in the enzymes in the nucleus, right? So whenever I have a problem in the nucleus, I'll have stippled RBCs. I have coarse and fine stippling, not required as of now, right? But stippled RBCs, you should be able to identify, right? Next, Leishman pneumothil blue. Leishman, single, multiple, multiple, uniform, not uniform, not uniform. Only here I have inclusion, right? That's your perfect Pappenheimer body. Okay, that's a perfect Pappenheimer body, right? Okay, Leishman pneumothil blue. Leishman pneumothil blue, right? It's blue in color. Single, multiple, single. That's your G6PD deficiency. Okay, it's very, very simple if you go with the system, but that system might take some time to remember. So that read the day before the exam, right? Leishman pneumothil blue. Leishman, single inclusion. That's how an oval jolly body looks. See, when I say single, it is single, one in one RBC. I can have multiple RBCs with single inclusion. That doesn't make it multiple. Multiple means it should be like this. Multiple in a single RBC, fine. Okay. So I hope you won't make any mistake with respect to RBC inclusions, right? Oval jolly, your Heinz bodies, basophilic stippling, golf ball inclusions, and your Pappenheimer bodies, fine. Okay. Next question. These are very simple questions. Whenever it's one-liner, we'll discuss more. Whenever it's a scenario-based question, we'll discuss less because it's easy, right? 40-year-old person, it's simple, right? In this question, this image is irrelevant. It's not useful at all. Mitral regurgitation, pansystolic murmur, and a cardiac biopsy. Most likely it is rheumatic heart disease. The entire structure is your Ashout body, right? This came in an AIIMS exam. So AIIMS or INACT being difficult is only in the head, right? Every exam will ask questions based on the diseases which is present in the book. That's all. FMGE, NEET PG, INACT, USMLE, PLAB, American exam, any exam. Remember one thing, no one in our country is capable of creating a new disease. If they are capable of creating a new disease, they won't be creating MCQs. So MCQs come only from the past diseases. So don't go behind the fad of recent advancements. Updates, not required. Updates will give you maximum 3 questions, 4 questions, maximum. The old chapters, no, will give you 195 questions in a 200 and close to 290 plus questions in a 300 exam paper. That is what is important. Updates are never important, right? Next question. First tell me the diagnosis, then let's look at what to work with. 29-year-old person, splenomegaly is present, massive splenomegaly, and the patient has a very classical finding of basophilia. Now tell me what is the diagnosis. Let's look at the answer soon. Tell me what's the diagnosis. Diagnosis, CML, right? It's chronic myeloid leukemia. You have the maturing immature cell. All these metamyelocyte, myelocyte, myeloblast, we call this shift to left. Okay, because the shift to left shift. They have left shift, basophilia, massive splenomegaly, only one diagnosed CML. The question is, what's the next investigation I will do here? Fine. Okay. Now I have 4 options. Lab score is useful in CML, but not in real life. Textbookish. Theoretically is useful. Real life it is not useful at all, right? Now the answer to this, like Nitin said, answer is FISH or PCR, right? Now let's look at approach to every leukemia. Why to look at only chronic myeloid leukemia? Let's take almost every leukemia, because every leukemia has a very simple approach, right? So when you have a leukemia, we divide leukemia into 2 major groups. We call it an acute leukemia. We call it a chronic leukemia. How do we divide acute and chronic? What's the basis of dividing something as acute or chronic? The base is very simple. If you have more than or equal to 20% blasts in PS for peripheral smear or bone marrow, I call it an acute leukemia, right? Very high immature cells. It can be either in PS or in bone marrow, right? If you have less than 20% blast and mature cells, we call it chronic leukemia. That's why the myelocyte, metamyelocyte, basophil are all mature cells. We call it a chronic leukemia, right? So if in acute, we have again acute myeloid, acute lymphoid. In chronic, again I have chronic myeloid, chronic lymphoid, right? That's how it is. We divide them into chronic and everything, fine? Now, I'll give few clues which should help you to diagnose all these leukemias, right? A child with, this is a very important age, child with generalized lymphadenopathy, okay? Lymph nodes involving the cervical, axillary, inguinal, right? Generalized lymphadenopathy. I have only two diagnoses in life. The first diagnosis, ALL, acute lymphoid leukemia. That's the first diagnosis. If it's not a leukemia, it could be Burkitt's. Burkitt's generally will not present with lymphadenopathy, at least for an exam. What will be the history for Burkitt's? Jaw swelling, right? Burkitt generally will be a jaw swelling. Why I'm emphasizing Burkitt's also here is age. Hematological neoplasm, which can happen in children, is only ALL and Burkitt. Nothing else will happen in child. Everything else is an adult or elderly only, right? Remember this, nothing else happens in children except for ALL and Burkitt. There's a subtype of AML called as AML M7 which can happen, but very rare, right? Okay, next. Where I have the same question saying adult with generalized lymphadenopathy. My first possibility is undoubtedly CLL. That's the first possibility, adult with generalized lymphadenopathy, fine? Okay. Now, an adult with massive splenomegaly. Can anyone tell me the diagnosis? It's a very simple diagnosis. Adult with massive splenomegaly. You must have definitely said about CML. I want to add one more, right? There's no fun if we don't read something extra, right? On a CML, the other is hairy cell leukemia. Both will be seen in adults and both will have massive splenomegaly, both CML and hairy cell leukemia. So how do I differentiate? CML will always have leukocytosis, okay? Will always have leukocytosis. Hairy cell leukemia will have pancytopenia. There are very, very less cells in the circulation and this will have leukocytosis. That's a main difference between CML as well as in hairy cell leukemia. Very, very important. Never forget this, right? Now let's come to investigation of choice or next step or whatever you want to call it. Fine. Okay. I'll give you simple clues. Follow the same order. Read the question carefully, whatever comes, and use the appropriate ones, right? So I have a patient with suspected leukemia. Okay. In peripheral smear, there is 35% blast. I'm just giving you a random scenario. Can I call this acute leukemia? Yes or no? 35% blast in peripheral smear. Can I call it acute leukemia? Yes or no? Yes, right? So next thing is, will you do a bone marrow examination? Required, not required? I'll write BM for bone marrow. Is a bone marrow examination needed? Not needed. If I know by default with a peripheral smear it's an acute leukemia, do I need bone marrow examination? I don't want a bone marrow examination, right? If it's sure in peripheral smear, the investigation of choice is flow cytometry. Don't do a bone marrow. If I can easily identify with peripheral smear, it is acute leukemia. I don't want a bone marrow, right? Next options. I presume it's leukemia. Peripheral smear as 13% blast. Can I call this an acute leukemia? Yes or no? What's your take? Can we call this an acute leukemia? No, I can't, because it's only 13. But my acute leukemia said that it's either peripheral smear or bone marrow. Now what's the next step? Should I label it chronic or should I do bone marrow? Because my acute leukemia diagnosis was simple, right? It's either or, it's not and, right? It's or. So should I do a bone marrow examination here, or can I call it directly chronic? I need a bone marrow, right? Only when I can't diagnose on a peripheral smear, then yes, do a bone marrow examination. Let's assume in bone marrow, it became 35% blast. Again, investigation of choices, flow cytometry. Okay, by default, investigation of choices, flow cytometry for every leukemia except CML. Acute lymphoid, acute myeloid, chronic lymphoid, it's flow cytometry, right? For ALL, AML, CLL, investigation is by default flow cytometry, and for CML, the investigation choice is genetics. I can either do a FISH or a karyotyping or a PCR. Flow cytometry will not help in chronic myeloid leukemia. Only there I do a genetic analysis as an investigation of choice. Fine. Okay. So leukemia approach is based on the question. Peripheral smear can diagnose things. I don't want a bone marrow. Peripheral smear cannot diagnose things. I do a bone marrow. For every leukemia, I do flow cytometry except for CML, where I use genetic test for diagnosis, right? Whatever permutation combination comes, never forget history. I didn't even talk about flow cytometry before history. History is first, then only everything else, right? Okay, next question. It's a simple question. Might be covered in pediatrics, OBG, multiple places. I just put some question because it needs representation, that's all. Okay, great, Rahul. Simple, Turners, right? I'm not going to talk about this. You know about Turners. Child, only one presentation which is missing here is primary amenorrhea. If primary amenorrhea is there, it completes almost entire thing about Turner syndrome. Nothing much to discuss here. The only thing is it's 45XO. This is the most common or only monosomy alive. Rest every monosomy will die inside the uterus. The only monosomy which is alive will be Turner syndrome, right? Okay. This came once in a NEET PG exam. Let's discuss this. We can learn multiple concepts in this question, right? Tell me what's your diagnosis, then we'll discuss about the question. Rahul has gone with C. Anyone else? A, B, C, or D. You will get 25% right any which way. Don't follow whatever the other person commented. They might be wrong. Okay, Nitin, Shri, Rahul, all of them with C. Okay, let's read the question carefully and let's see what will be the answer. 21-year-old trainee, OPD, present with bleeding gums, fever for 2 months. Bleeding gums and fever. Will TB present like that? Is that a presentation for TB? TB without cough, expectoration? Unlikely. Let's ignore. Whenever it's a scenario-based question, try to exclude like this. First read all the 4 options, then we'll come back to that. Fine. Okay. General examination showed paler. Yes. Lab shows hemoglobin of 3.1, TLC of 1600, platelet of 14,500. So can I call this pancytopenia? Definitely I can call this pancytopenia. A, B, C, all 3 of them can have pancytopenia, right? Peripheral smear shows macrocytes and retic count of 0.5. That's a very important clue here. Okay, I have a retic count of 0.5. Okay, the normal reticulocyte count is 1 to 1.5% in an adult. So now here, retic count is less or retic count is more? What do you think is happening? Reticulocyte count is less or more? Retic count is less, right? Perfect. Okay. So now, what does reticulocyte mean? Can I say reticulocyte count is a predictor of the bone marrow's function? Is that statement right? When the bone marrow proliferates faster, retic count will become more. When the bone marrow proliferates slowly, reticulocyte count will become less, right? Retic count is a method to assess RBC or erythroids formation. That's what retic count is, right? PNH, hemolytic anemia. When there is hemolysis, what will happen to retic count? This is an hemolytic anemia, right? When there is hemolysis, what will happen to retic count? Retic count will, I'm losing blood. Will my bone marrow compensate? It will compensate. Retic count will increase. That's what will happen for every hemolytic anemia. Retic count will not reduce, it will increase. So not the answer. Myelodysplastic syndrome. This will have blasts in microscopy. It will not have fatty streaks. Necrosis is not a problem here. It will have blast. It's a dysplastic syndrome. Again, not the answer. So the only one left out here is aplastic anemia, right? So there are multiple things to remember here. Retic count is an important parameter for assessment of aplastic anemia. It's the only disease with reticulocytopenia, right? Okay, when retic count is reduced, two possibilities. If it's reduced retic count, one, it could be an aplastic anemia. Aplastic anemia is only anemia or pancytopenia? It's pancytopenia, right? Remember that. It's not only anemia, it's pancytopenia. And then I have one more disease called as PRCA. Have you heard PRCA? PRCA is pure red cell aplasia. If only red blood cells alone is going away, that also will have reduced retic count, right? PRCA, right? This also came once in exam. There's a virus which causes PRCA. Anyone? That virus also has one more appearance called as slap cheek appearance. That virus causes PRCA, right? Your parvovirus causes PRCA. And also one tumor, Psammoma, PRCA is a paraneoplastic syndrome, right? Parvovirus destroys only RBCs, nothing else will happen to the others. So if there's a reticulocyte count reduced, look whether it's completely all the three lineage affected, RBC, WBC, platelets, aplastic anemia. Only RBC, pure red cell aplasia, right? These are only two places where retic count will be reduced, fine? Perfect. Okay, let's go to the next question. This is a simple question. It's just kept it for namesake. These are very, very simple ones. You must have also encountered this condition in life, right? Definitely at some point of time, right? 95% living till 95 itself is a problem. Touches a hot pot of boiling water, you have a boil, right? She is marked erythema of the skin and fingers. Small blisters appear in the finger pads. Okay, definitely not fibrinous. It's blisters. No granulomatous, acute, pus or serous. Not pus because it's a blister. Blister means it's fluid filled. If it's pus filled, I will use term pustule. Okay, pustule means yes, I will think of a purulent inflammation. Since a blister, it's a serious inflammation. You also must have got this inflammation. It's one of the outcome of inflammation, that's all. This can get infected also. That time it can become a purulent infection, fine? Okay, it's a very simple question to remember. Okay, next question. After this question, we'll have maybe a 5 minutes break and then we'll come back. Okay, go have a coffee or a water and then come back. A child, this also is a very good question, has good scope for us to analyze and learn few things. What's the answer? Ketones, B. You guys don't think for a PYQ, right? PYQ, suddenly fire the right answer, right? Okay, child with palpable blanching purpura, abdomen pain in the knee joint resulting from arthritis. Urine examination showed hematuria, proteinuria. What's the most likely diagnosis, right? Okay, so we have a purpura, we have abdomen pain, we have joint pain, we have kidney problem, hematuria, glomerulonephritis, right? Now let's take ITP. Can ITP have purpura? Yes. Can ITP have hematuria and arthritis? No, right? ITP, the only thing which fits here is purpura. That's the only thing which fits here. Rest everything is not a fit, so it's not an answer. ITP is only thrombocytes or platelets being destroyed, right? Okay, perfect. HSP is the right answer. We look at the lab. Schuck-Strauss syndrome, right? Schuck-Strauss syndrome is a vasculitis. It's a small vessel vasculitis. Can they have hematuria? They can have hematuria because When it's a small vessel vasculitis, it can involve glomerulus. Glomerulus is also capillary, right? This can have purpura, yes. This can have hematuria, yes. Will it have joint pain, arthritis? No. Other things will not have. Yes, I'll have increased eosinophils. Other things I might not have, but these two I'll have. But since I won't have arthritis and Churg-Strauss syndrome, we are ignoring that. Dengue fever. Can it have purpura? By default. Will dengue have arthritis? Dengue's predominant presentation is bone pain, right? So dengue fever also can have purpura because dengue will have dengue or dengue, whatever you call it. Platelets will reduce, will have this. Arthritis or bone pain, not exactly arthritis, will have it. But kidney involvement, hematuria is unlikely. Abdomen pain is unlikely, right? So it's not dengue. So let's take HSP. HSP is also a type of vasculitis. It's an IgA mediated vasculitis. It's also a small vessel vasculitis. Okay. HSP is a classical finding seen in children. Most common presentation will be more than purpura. It will be abdomen pain will be the presentation of HSP because the vessels of the abdomen, tiny vessels of the abdomen have the problem, right? Abdomen pain and also the purpuric rash, especially in the back and thighs, right? In the buttock region and in the thigh. That's a very classical symptom or sign of an HSP, Enoch's colon purpura, right? Yes, since it's IgA involved, it can form IgA nephropathy. That's why the patient is having your hematuria. Yes, it can also cause arthritis. Okay, so all these are classical presentation of an Enoch's colon purpura or HSP, Enoch's colon purpura. You must have read this in pediatrics as well, right? This is a very classical question for an HSP. Fine. Okay. Now it's 5:02. Can we start by 5:07? Just 5 minutes, just to relax. Sitting for a long time is not good for you, for me, and for everyone, right? 5 minutes. I won't do anything. It'll be the same link. I'm not going to close. I'll just shut down the computer and then I'll start again. Okay. See you by 5:07. Hey guys, back. Shall we continue? Shall we start? Hello, hi, hello. Sri, Bhargavi, Nitin, Atul, Rahul, ketones. Okay, so let's go ahead again. So read the question and tell me what's the right diagnosis. What do you think is the right diagnosis? Then let's go to the discussion. 49-year-old person came to the outpatient department with fatigue, tiredness, cervical lymphadenopathy. TCNDC is normal, no immature cells. A lymph node biopsy is performed, which was diffuse effacement of lymphoid architecture. Intended nuclei, prominent nucleoli, atypical cells, which are CD10 and BCL2 positive. What's the likely diagnosis? Anyone? What's the answer? Are guys there? Not at come? Or my comment system is not working? I'm waiting for you guys to come. Okay, Shri is back. B. Anyone else? Rahul B. Okay, fine. Now let's have a quick look at lymphomas. Fine. Lymphomas, the biggest issue with lymphomas, the entire diagnosis is based on CD markers. Whatever lymphoma it is, history is same, lymphadenopathy. Microscopy, more or less same, except for few things like Burkitt's lymphoma, Starry's appearance. More or less lymphoma will have this word. Any question says diffuse effacement, which means I am talking about a lymphoma. That's how it is. But there are few clues which will tell me what type of lymphoma it is. Like I said, jaw swelling child, Burkitt's lymphoma. There are few clues. We are going to look at the diagnostic markers and few classical diagnostic clues. Fine. Okay. Diagnostic markers. If you look at CLL, your mantle, marginal, follicular and marginal. We have Burkitt's lymphoma. All these will come under non-Hodgkin's. And obviously we have the classical guy, Hodgkin's lymphoma, right? And we have something called a DLBCL. Have you heard about DLBCL? Diffuse large B-cell lymphoma. There's something called an ALCL. ALCL is anaplastic large cell lymphoma. Okay, so I'm going to just tell you clues for each of these lymphomas. If the question is coming in this lymphoma in the form of clinical scenario, this clue will be present by default, right? Just classical clues. Again, this table, whatever this thing is, take a screenshot, read the day before the exam, fine? CLL bar mantle, the diagnostic clues, one is smut cell. Smut cell present for an undergraduate, it is CLL, right? Is most common and natural is DLBCL by default, fine? Smut cells are equivalent to CLL in case of an the undergraduate level at least, right? If you want to go for a markers, CLL is a tumor which will be positive for CD5, CD23. I am writing only the positive markers here. 5 positive, 23 positive smut cells present CLL. Mantle, only one marker which I am more inclined towards, cyclin D1. Don't worry about 5 and 23. Mantle is 5 positive, 23 negative. Doesn't matter. If you want, you can add it. It's 23 negative tumor. But the most important thing for me is cyclin D1. Cyclin D1 positive has to be mantle. Follicular, it's BCL2. BCL2 positive, it has to be follicular. Why these single markers are important? All these genetically related, right? Follicular lymphoma has a translocation called as translocation 1418. And in chromosome 18, I have your BCL2. Mantle cell lymphoma has a translocation called as translocation 1114. And in chromosome 11, I have cyclin D1. That's why it's very, very important. If this marker is there, it's a finding. That's how it is. 14 is always common for everything, right? Marginal, you'll have recurrent inflammation. Whenever there's a recurrent inflammation in the history, think of marginal. Like recurrent thyroiditis. can cause thyroid maltomas or marginal zone lymphomas. Recurrent chronic gastritis can cause gastric maltomas or gastric marginal zone lymphomas, right? Any recurrent inflammation is marginal or maltomas. Burkitt's, obviously history is there. I'm not repeating the history, right? So we have translocation. Nitin, I'm not going for marginal translocation because it's multiple. If there's one translocation, it's worthwhile to remember, right? 8, 14. 14 is again common. 8 for Burkitt. Perfect. And it is CMYC. Okay. CMYC, CMYC is a classical marker because 8th chromosome has the MYC gene. That's a classical marker for Burkitt's lymphoma. And obviously you guys know the Stargardt appearance, right? Hodgkin's, I'm not going with the translocations. You know about Hodgkin's. We have something called classical Hodgkin's lymphoma. Classical Hodgkin's lymphoma will be 15 positive, 30 positive, and PAX5 is a marker which will be weakly positive. This is seen in classical Hodgkin's lymphoma. One more type of Hodgkin's lymphoma, we have something called NLPHL, nodular lymphocyte predominant Hodgkin's lymphoma. That will be CD20 positive, CD45 positive, and PAX5 here will be strong. It will be strongly positive in case of an NLPHL, right? So PAX5 will be weak in classical, PAX5 will be strong here, but 20 positive, 40 positive, both are Hodgkin's, one is classical, one is NLPHL, right? DLBCL, the clue here is the microscopy will have large cells. It will not be small cells, but they are 20 positive. 20 positive large cell, DLBCL, diffuse large B cell lymphoma, right? ALCL, it's ALK positive. That's ALK is anaplastic lymphoma kinase, positive in anaplastic large cell lymphoma, right? It's a T cell lymphoma. It's not a B cell lymphoma, it's a T cell lymphoma, fine? Okay, so these are classical markers in the commonly asked lymphomas. These are definitely, most of these lymphomas has come in an exam till now, right? Let's go and have a look at few rare things also. This might not be primarily topics in pathology, but I'm sure you must have read this, right? Where have we come across the term mycosis fungoides? Heard in dermat, right? This is cutaneous lymphoma. It happens in skin. This is CD4 positive cutaneous lymphoma, right? CD4 positive cutaneous lymphoma, I think of a mycosis fungoides. You must have definitely heard about this in dermatology, right? Perfect. So next, we have something called an adult T cell lymphoma. Adult T cell lymphoma, again, is very, very rare. This also is CD4 positive T cell lymphoma. We have a type of cell called an clover leaf shaped cell. Have you seen a clover leaf? It looks like a, you must have seen the emoji, right? Green color emoji in your WhatsApp. Most of the uncles and aunties will keep selling that, right? So that thing, it'll have lots of flower like cells, clover leaves like cells, and this is positive for HTLV1. That's a virus which causes it. That's positive here, right? So clover leaf shaped blast or immature cells will be there in case of an adult T cell leukemia lymphoma. Not very common, but it's very classical finding here, right? So this is more than enough for you to remember in case of lymphoma leukemia. It's only based on immunohistochemistry because lymphomas leukemias clinical symptoms might not help you much. It's always based on IHC. Please don't remember every IHC, right? Remember only things which is required, right? Few things alone you remember it, others don't do it. Okay, fine, perfect. Let's go to the next question. Tell me what's the answer. Answer. Nitin, start with B. Great. Right, it's a very simple question. Right? Can anyone tell me, and you know the answer, can anyone tell me what this is? What's the microscopic findings name? Answer is very easy. What's the findings name here? So here, the patient is having an alcoholic liver disease, right? And in the microscopy, what I'm seeing is an intracellular eosinophilic inclusion in the hepatocytes, right? So what happens actually here is a normal hepatocyte, let's assume this is a normal hepatocyte with lots of pink cytoplasm, right? Normally hepatocytes will have a very pink cytoplasm. When the person consumes alcohol, the aldehyde of the alcohol is a toxin, right? So the aldehyde kind of destroys the intermediate filament or destroys the cytokeratin, right? It's not cirrhosis, The cytokeratin 8 and 18, these are the cytokeratin numbers seen in case of an hepatocyte. That will be destroyed, right? It's a protein. Once you destroy a protein, it will become darker or lighter? Dark or light? Darker or lighter? Protein destruction always will make it darker. It will never make it lighter, right? Because every protein, once it's destroyed, it becomes a precipitate, right? So what happens here is, it will make the entire protein, once it's destroyed, it will make it darker and looks like a precipitate, right? Again, remembering it's a nucleus. This structure was identified by a person called as Mallory. Have you heard this? Mallory. The older name was Mallory-Hyalin. The newer name was Mallory-Denk body. Okay. It's a finding seen in case of an alcoholic liver disease, right? It's due to destruction of cytokeratin 818. Now listen carefully and answer. If it's due to destruction of cytokeratin, will only alcohol cause a destruction, or hepatitis also can destroy it? Can hepatitis destroy? Autoimmune hepatitis, viral hepatitis, any other liver disorder, can it destroy? It can, right? So Mallory-Hyalin or Mallory-Denk was a very non-specific finding. It's not specific to alcohol. Any hepatocellular problem which destroys the intermediate filament cytokeratin can cause Mallory-Hyalin or Mallory-Denk body, right? Intermediate filaments is the answer. A type of intermediate filament is called cytokeratin. This is an intermediate filament seen in epithelial structure. Okay. There are few more intermediate filament. I'll tell you. You tell me what they are. There are few intermediate filaments which are seen in mesenchymal tissue. Can anyone tell me what's the intermediate filament seen in mesenchymal tissue? I'm writing IF for intermediate filament. Or which is the marker for mesenchymal tissue? 𝐌𝐿. This also is an intermediate filament seen in mesenchymal tissue. There's an intermediate filament seen in neurons. Not neurons, let's say astrocytes or CNS. That's your GFAP, glial fibrillary acid protein, right? So this also is an intermediate filament only. Okay, it's glial fibrillary acid protein. So all these are examples for intermediate filaments, including your cytokeratin, 𝐌𝐿, desmin. Perfect, right? Desmin is seen in, not in every mesenchyme, in muscle protein. I have desmin. That's also an intermediate filament seen in muscle parenchyma. That's an intermediate filament, right? So all these are used for markers for diagnosing tumors in future. Fine. Okay. Select the correct statement regarding telomerase theory of aging. Telomere stability is associated with aging. Now, if telomere is stable, it's not associated with aging, right? Abnormal telomerase activation is associated with aging. No. When telomerase is activated, it will not let the telomere become shorter, right? Increased telomere length is associated with aging. No. Reduces associated with aging. Obviously, decreased telomere length is associated with aging, right? The only problem of these questions is, these questions are very easy, but very long options, sometimes you might make a silly mistake. So please spend some time. It's okay to make get like 10-20 seconds extra, but don't be in a hurry, because it looks correct. This also looks correct. If I don't read it carefully, you will make a mistake, right? It's a very simple concept of telomere. You know how telomere works. Every cell division, the end part becomes smaller. After a point of time, it cannot divide. The entire cell dies, right? Great. Okay, diagnosis. Read the question, tell me the answer. What do you think is the answer? B. Okay, see, this electrophoresis question is a very simple question, right? One is this: recurrent abdomen pain, chest infection, blood transfusion is being given. That might not be very much important, but here I have both HbF and HbS. Actually, there's no HbA. There's no hemoglobin A. I have hemoglobin H and hemoglobin S, which makes my diagnosis very simple to call it a sickle cell disease or a sickle cell anemia, right? So now let's try to identify electrophoresis. If I'm given an image, also it's very simple to identify, not just a theory, right? Let's try to identify electrophoresis. Electrophoresis, there are few rules. There are a few thumb rules for electrophoresis. First rule, always compare with the normal. Normal will be there in the electrophoresis. Without normal, no one in the world can identify electrophoresis. Always compare, right? Second rule, if there is HbA2, if this HbA2 is prominent, right? The HbA2 is prominent, A2, think of thalassemia. Okay, think of thalassemia most of the time, right? Third rule, if HbF is present, if HbF is elevated very high, this means it's a severe hemolytic anemia. Because compensation, right? Only in severe hemolytic anemia, HbF will be very high. What I'm trying to say is, sickle cell anemia was a sickle cell carrier. Carrier will not have very high HbF. Only sickle cell anemia will have. Beta thalassemia trait versus beta thalassemia major. Major will have more HbF. Trait will not have more HbF, right? These are only clues which I want you to remember when you're discussing about hemoglobin electrophoresis. I'll show you a simple hemoglobin electrophoresis. You tell me what's the answer. Just for you, this is control. This is not the patient. Okay? Let's say 1, 2, 3, 4. We have 4 patients. I want you to diagnose it, right? Just 3 rules. Compare with the normal. If A2 is more, think of thalassemia. If F is more, think of severe hemolytic anemia, right? Now here, what are the bands I'm having? I'm having HbA. F is not more. Compare this. A2 is definitely more. I have HbA2, right? I have A2 and no F. What do you think is the answer? If A2 is present, what do we think? We think of thalassemia, right? So this thalassemia trait or thalassemia major? Thalassemia is a very primitive diagnosis, right? Thalassemia major or thalassemia trait? Is F there? F is not elevated. So this is thal trait, right? That's how I pick up thal trait or the carrier state, right? Now let's look at the second patient. A is not there, but F is very high in this patient. A2 is also there, right? So in this patient, HbF is high, HbA2 is high, right? It's not major, it's trait, right? Because F is not high. Only when F is high, it's a severe hemolytic anemia that makes it major. Okay, Shri and Nathan. Now tell me what is diagnosis here. Second patient, what's the diagnosis? A2 is present, so it is thal, right? F is also very, very high. So severe thal or less severe thal? Severe thal. So this will be a thal major, right? Clear? So thal, if it's major or homozygous, I need F also to be elevated, right? Now let's look at this third patient. This is A, this is F, just for a comparison, right? A is present here, HbA is present here. HbSF is not very elevated, but HbS is present. So this patient is sickle carrier or sickle cell anemia, full blown. Carrier or homozygous? This patient is a sickle, trait or heterozygous or a carrier because F is not very, very high, right? Perfect. Next patient, F is more, S is also more, but there is no A, right? So this patient has HbF, also has HbS. So this patient is a sickle cell anemia or a sickle homozygous, like in our patient, in our case. It's a very severe sickle cell anemia because both of them are present and there's no A at all, right? Clear? Thumb rules are very simple. Always compare with the normal. Look for HbA2. If HbA2 is prominent, think of thalassemia. If HbF is very prominent, think of a severe hemolytic anemia. Those are things which require. Other things will be easily solved, fine? If you look at this, only 2 ways are present. So I think of an HB sickle cell anemia, fine? Okay. Next. It's a very simple question. What's the answer? This is okay. Now let's look at this. What's the structure? That's a classical OR rod, right? It's a very classical OR rod. OR rod means I'm going to think of a myeloid leukemia. In this image, the OR rods are very high or very less. AML is a very easy question. OR rods are very high or very less? It's very high number of OR rods, right? So when you have extremely high number of OR rods, we call it a faggot cell. Okay, faggot cell is classical finding in AML M3, or we use the term APML, acute promyelocytic leukemia. In acute promyelocytic leukemia, the problem is translocation between 15 and 17, right? It's a 15-17 translocation, which is going to result in an extremely high density of OR rods in case of an acute promyelocytic leukemia, right? So you are right in calling it an AML, right? So this is the right answer. 11-14 is seen in mantle. 14-18 is seen in follicular. 9-22, you know, it's seen in CML, right? OR rods, AML, my diagnostic answer is translocation 15-17, right? There are one more thing which I want you to remember. Acute promyelocytic leukemia is the only leukemia which can present with DIC. It can present as disseminated intravascular coagulation. That also is very unique. And treatment for this leukemia is also unique. Treatment here is ATRA. ATRA is nothing but all trans retinoic acid, which is nothing but vitamin A. We give vitamin A. Chemotherapy, we give vitamin A. Yes, AML M7 can be seen in Downs. This M3 subtype causes acute promyelocytic leukemia. Fine, great. Diagnosis. Actually, this image is not required here. You can look at the history and tell the diagnosis. I told this clue before itself. What do you think is the answer? Simple, right? Child with a swelling in the jaw. The answer is straightforward. It has to be a Burkitt's lymphoma. Fine. Okay. Complaints of swelling in the jaw. 7-year-old kid, has to be a Burkitt's lymphoma. Actually, this image also gives us a little bit of clue. Fine. Endemic Burkitt's. Endemic Burkitt's, sporadic can also happen in jaw, but endemic happens most commonly in jaw. Fine. So this image we call it Burkitt's blast. Okay. So Burkitt's blast has two classical findings. One, it is a very blue cytoplasm. Generally, cytoplasm will not be this blue. It has a blue cytoplasm, and second thing, it has vacuoles in the cytoplasm. Okay. This also is a very classical clue. This is not the starry sky. Starry sky appearance in Burkitt's happens in case of a lymph node, right? So Burkitt classical finding, everyone knows is starry sky. That happens in lymph node. That does not happen in the bone marrow. In bone marrow, we have the Burkitt's blast, which is a classical blue cytoplasm and lots of vacuoles like this. And that's a classical diagnosis here. Fine. Okay. Options and answer. What do you think is the answer? It's more of a microbiology question. Just took it in between. You must have read about lots of viral inclusions in microbiology. This is one example of viral inclusion. It's simple, right? Classical owl's eye appearance, it has to be a CMV. See, owl's eye is there in two places in pathology. If I can take CMV also as pathology, Hodgkin's lymphoma RS cell is also owl's eye, right? Same time, CMV virus is also owl's eye. How do you differentiate these two? How do you differentiate Hodgkin's and CMV? Hodgkin's owl's eye is pink in color. CMV is basophilic, blue in color, right? Generally, you will not be required to differentiate this because Hodgkin's and CMV are not differential diagnosis, right? One inclusion will be basophilic, that is your CMV, and this will be pink in color, that's your Hodgkin's, right? Perfect. But it's not differential diagnosis. If it's just a spotter, you need to know the difference. Fine. Okay. Next. There's an overlap between surgery and your pathology. What's your answer? What do you think is important? B, C. Okay, others? There are two different options. Let's see what will be the right answer. B or C? C. Okay, let's discuss. So the 55-year-old person with a lump in the breast evaluation shows IDC of right breast, which are the marker confers a good prognostic sign in this patient. Fine. Okay, first question, Nitin, you said it's B, right? If BRCA is positive, let's assume it's the right answer, right? Just to negate what about your thought process, that's all, right? If BRCA is positive, do you think it's good for the patient or bad for the patient? What's your take? If BRCA is positive, good for the patient, bad for the patient? It's bad for the patient, right? So ultimately, it's not a good prognostic sign because BRCA is an inherited cancer. Inherited cancer is very early in age and it's bad for the patient, right? So by default, if it's a good prognostic sign, ER positivity is a good prognostic sign because if ER is positive, we can give hormonal therapy, right? You must have read about all the serum estrogen receptor modulators, SERMs in your pharmacology, right? So that therapy can be given if ER is positive, right? So there are 3 or 4 markers required for us to differentiate the breast cancer based on the molecular basis, right? We have something called a molecular classification of breast. This is important. We have to remember this. Okay. So we do ERPR, estrogen progesterone receptor. We do one more thing called an Ki67. That's a proliferative marker, right? And we have one more thing called an HER2/neu. I'm sure you know the HER2/neu, right? So based on this, if ERPR is positive, Ki is less than 14, HER2/neu is negative, we use term luminal A. Luminal A has the best prognosis. They have the best prognosis. That's the first category of molecular classification, right? Then we have something called luminal B. Luminal B has 2 subtypes. One is ERPR positive, Ki more than or equal to 14%, HER2 negative. That's also luminal B. If Ki is more, very highly proliferative, little bit less prognosis. Or ERPR positive, HER2 positive, any Ki. It can be 1 or 2 also. If HER2 is positive, Ki is not important for me. If HER2 is negative, I look for the Ki67, right? This is luminal B. Then I have HER2 enriched. As the name says, only HER2 is positive. For this patient, the targeted therapy of trastuzumab or Herceptin works, right? Last but not least is triple negative. Most of the BRCA related cancers are triple negative. Okay, BRCA1 related cancers are generally triple negative and they have very bad prognosis because nothing is positive. So this is negative, everything is negative, it's triple negative, right? This table can also come handy when you go to surgery. They'll teach you this again and they'll also tell you how to treat as well, fine? This is very important for every patient who has breast cancer. Without doing ERPR, HER2/neu and Ki, treatment does not start. So pathologists know this, surgeons know this, you have to know this, fine? Okay, let's look at the next question. It's actually a one-liner. It's been created through 3-4 lines. What's the answer? It's C, right? 𝐒𝐿 polyp is a type of polyp called as an hematomatous polyp. That's the only thing. 𝐒𝐿 polyp is a type of hematomatous polyp. Just remember, but the most common hematomatous polyp is not 𝐒𝐿 polyp. It's a type of polyp called as an juvenile polyp. Okay, juvenile polyp is the most common hematomatous polyp. 𝐒𝐿 also is a hematomatous polyp, right? Once there's a question in NEET PG exam which came about with respect to juvenile polyp, right? What will be the most important clue for juvenile polyp? Can anyone tell me that? The most important clue in a juvenile polyp. Because we have 𝐒𝐿, juvenile, villus adenoma, multiple polyps in the GIT. The most important clue in juvenile polyp is, don't think too much, age, right? Always be wide. Don't go with very important, you might ignore it. But age is the most important clue in juvenile polyp. The question said 5-year-old kid with polyp in the rectum. It should be only one polyp, juvenile polyp. Don't ignore the age. Age symptom is much more important than radiology or pathology or markers any day at any point of time, right? Please don't forget that. Okay, next, let's see the 2-step here. First we have to identify the diagnosis, identify what cell it is, and then come to the answer. Tell me what cell is that first, then let's go to the right diagnosis. 25-year-old patient came to OPD, evaluation showed the below image. What will be the next step? Okay, no takers. Let's learn. What's the shape of RBC? What is the shape of any RBC? Okay, Sri has gone to spherocyte. Let's see. What's the shape of any RBC? Biconcave, right? A normal RBC is biconcave disc-like, right? It's a biconcave disc-like shape is the normal shape of an RBC, right? If an RBC is biconcave, the hemoglobin will stay here because the disc, in the center it will be pressed. Only in the corner you'll have hemoglobin, right? So when I look in a microscopy, always the RBC will be like this. Periphery, there will be paler. Periphery there will be hemoglobin and there will be a central pallor. Central pallor is diagnostic of a normal RBC, right? Now let's say I have a disease of an spherocytosis. Okay. In spherocytosis, as the name says, the RBC becomes spherical, becomes round. So can I say hemoglobin will be uniform here? It will be, right? It will be uniform here. So will there be a central pallor? When I see from top also, I will not see a central pallor, right? Central pallor will not be there, right? So how do I identify spherocytosis? They are smaller RBCs, they are darker RBCs, and there will be no central pallor. So that's the first step in this diagnosis, right? So if I diagnose then we look at what's the answer. Fine, look at this. So can I say this, all these, they don't have a central pallor? They don't have. They are completely dark compared to these areas. Though this also is not having a clear central pallor, but central area is somewhat pale. If you look carefully, it's not exact same color. Can you see the pallor in the center here? Compare these two. The central pallor is not pale. Central pallor not pale, right? So a spherocyte will not have a central pallor. They'll be smaller, darker, and no central pallor, right? Now I know this is spherocyte. Okay. So now my first step of the job is done. So the peripheral smear has spherocytes. The most common cause of spherocytosis is autoimmune hemolytic anemia and not hereditary spherocytosis. That is also a cause, but that's not the most common cause. So there's a very repeated question. Whenever you see spherocytes or spherocytic anemia, the next step to be done is to rule out autoimmune hemolytic anemia. That is, do a 𝐒𝐿𝐵's test. Please don't diagnose spherocytosis. Diagnose autoimmune hemolytic anemia first. If it's not there, then let's think of spherocytosis, right? Let's go back to the question. 25-year-old with a spherocyte, I think of this. HS stands for hereditary spherocytosis. OFT stands for osmotic fragility test. I won't do this first. My first diagnosis is always the acquired one, not the genetic one. So obviously I'll think of an autoimmune hemolytic anemia and your 𝐒𝐿𝐵's test. That's the way you're going to diagnose that. Fine, perfect. Okay. This is also a simple one-liner. I'm sure one-liners you guys are champs, right? What's the answer? HHV8 is related to all of the following except. Please don't leave except. Except is also very important here. We already know this. We have discussed this, right? She already said that adult T-cell leukemia lymphoma is caused by a virus called an HTLV, right? This is caused by a virus called an HTLV. Rest everything are due to HHV8 or human Kaposiform virus 8, right? It causes Kaposi sarcoma, primary effusion lymphoma, and also Castleman's disease, right? All of them are caused by HHV8 virus, fine? Okay. Next, what's the answer? Read, tell me the answer. This question has 2-3 separate questions, all of them united to a single question. She has gone with B. Actually, there's one very important clue here. Spike and dome is a very, very important clue here. Okay. Perfect. Okay. Kaushik has gone with B. Fine. Let's talk about first thing here. Is this patient a patient of nephrotic syndrome or nephritic syndrome? What do you think? Nephrotic or nephritic? Aryan is going to be as well. It's a nephrotic syndrome, right? It's a classical patient in nephrotic syndrome. Okay. So in this presents as nephritic syndrome. Okay. The rest of the three presents as nephrotic syndrome only. FSGS is very common in elderly age group, 20-year-old unlikely. Minimal chain disease and membranous are the only differential diagnosis for now. Minimal chain disease, microscopy will be normal. There will be no change in the glomerulus at all. So if you have some change, by ruling out also the answer is membranous glomerulonephritis, right? But I am sure that you must have known that in case of an MGN or membranous glomerulopathy, there are few things to remember. There will be antibodies to PLA2R. This is approved as a diagnostic method by FDA, so remember them. I don't want a kidney biopsy now. Just do a blood test and prove it is membranous glomerulonephritis. And microscopy, you have the classical spike and dome appearance. Spike and dome appearance is actually a finding seen in silver stain, not in normal H&E. This is a silver stain finding. In normal H&E, you will have a thick membrane or a thick glomerular basement membrane or a thick capillary as a diagnostic finding, right? Okay, Shri, osmotic frigidity is not important at all. Okay, 𝐒𝐝 test is something which is an antigen. Have you heard about erythroblastosis fetalis? There also we do the 𝐒𝐝 test. What I do is I take the patient's RBC, I add an antibody to see if it's binding and causing clotting. Similar concept of blood grouping. That's the concept of 𝐒𝐝 test, fine. Osmotic frigidity test, what we do is we take the RBC and put it in hypotonic saline, right? If I put in a hypotonic saline, I just go up for a second. I have two RBCs here. One is bigger, one is smaller. Spherocyte is smaller, which can accommodate more water. Normal RBC can accommodate more water because spherocytes are smaller. So with less water itself, it will burst. When I put in the hypotonic saline, water comes inside by osmosis. Spherocytes burst a bit early than a normal RBC. That's the difference between osmotic frigidity of spherocyte and a normal RBC. Right? It's not used these days because it's a very cumbersome procedure, very difficult to do, and I have better diagnostic procedure for spherocytosis, right? But that's the concept of osmotic frigidity test. Okay, coming back to this diagnosis, like you guys said, it's a membranous glomerulonephritis. Fine. The next one. Again, the first question here is it nephrotic syndrome, nephritic syndrome? Nephrotic, nephritic. It's nephritic, right? Hematuria is present, it has to be nephritic syndrome, right? What is the most common diagnosis? Because I have a skin infection and then after few days or weeks, the patient has hematuria. Skin infection, hematuria. So diagnosis, PSGN, right? Post-streptococcal glomerulonephritis, right? Post-streptococcal glomerulonephritis by default will have subepithelial deposits. Okay, there are subepithelial deposits. Electron microscopic deposits, we'll have a tiny table to remember them. These are the common things, right? Subepithelial deposits will be seen in case of PSGN and also membranous glomerulonephritis. Fine. Subendothelial deposits can be seen in case of your SLE, lupus nephritis, or an MPGN type 1, membranoproliferative glomerulonephritis type 1, right? Intramembranous deposit will be seen in case of an MPGN type 2, that's the older name, or I have a newer name called C3 glomerulonephritis. Okay, I'm just writing C3GN, GN for glomerulonephritis, right? There's one more thing, mesangial deposit. Mesangial deposit, the first possibility I want you to think of is IgA nephropathy. Okay. All these are electron microscopic deposits in the different locations, right? Subepithelial is common, PSGN versus MGN. How do I differentiate this both is? MGN is nephrotic, PSGN is nephritic. There's a very easy difference to differentiate them. SLE is a type of MPGN type 1, MPGN type 2 and C3 glomerular intramembranous, mesangial is classical IgA nephropathy, right? So these are few things I want to remember for electron microscopy, though not very important, but is required, right? I'll add one more electron microscopic finding. You tell me what disease. Effaced food process. This can come in an exam. Which of the glomerulonephritis will have effaced or destroyed food process? It's a classical finding. That's your minimal change disease. Okay, perfect. In minimal change disease, the entire food process will be destroyed or effaced. MCD is a classical finding of minimal change disease. Again, I don't require electron microscopy to diagnose that, but that's a classical finding seen in minimal change disease. Fine. Okay, next question. Answer. Answer. Was the answer in the test given as option A for this question? Was the answer in the test given as option A? Yes, no. Yes, so you accepted it's option A. Okay, Aryan is Aryan, I think you didn't give the test. That's good. See, now here, what is important here is it's an error from my side. Apologies for that, first of all, right? I also oversaw the question and gave the answer as option A. So it's B12 deficiency versus folate deficiency, right? That's how I have to differentiate them, right? Atul, megaloblastic anemia, be it due to B12 or be it due to folate, both of them will have hypersegmented neutrophil. It's a specific finding for megaloblastic anemia, but that will not help me to differentiate hypersegmented neutrophil due to B12 or hypersegmented neutrophil due to folate, right? Okay, pencil shaped things are seen in IDA, iron deficiency anemia, right? Now the question is how do I differentiate B12 versus folate? Okay, so there are a few things which are common for both. One is macrocytes, which is common for both. It's seen in both B12 as well as folate. Your hypersegmented neutrophil, seen classically in B12 as well as folate. Okay, let's look at the difference. Okay, I'm giving you a classical history. Tell me where it is seen. Patient who is a vegan, which will be commonly seen in vegan diet. Vegan means eats fruits, vegetables, no animal protein, no milk. Vegan history is for B12 and no for folate, because the most important and the richest source of folate is fruits and green leafy vegetables. Because when you consume more and more in fruits, you'll get B12, you'll get folate. B12 will not come from that. B12 comes from milk or from animal protein only, right? If the person's diet has no fruits or greens, which deficiency will be there? It'll be folate, and here no, right? Because the only good source of folate is fruits, right? It's not anything else, right? I'll tell you a very important different look from how human beings have spoiled all the diseases, right? I'm sure you must, Dr. Oshika or your OBG teacher must have taught you that folic acid should be supplemented for pregnant women. From what time? From what time do we need to supplement folic acid for pregnant women? It said that at the time of conception, right? If someone is planning to become pregnant, they say that in these days you have to keep supplementing folic acid, because if folic acid reduces, the kid can have neural tube defects. This is the recent guidelines. When I was reading my MBBS, that time it was said that during the first trimester, you give folic acid. Now I'm giving folic acid 3 months before, right? While planning pregnancy. The reason is, when was the last time you ate banana? Do you eat banana daily? We don't. Do your parents eat banana daily? They do, right? Fruit consumption is reduced a lot. I'm not talking about apples and costly fruits. Normal fruits, as simple as banana, is reduced a lot. Because folate is there in milk, folate is there in meat, but when I cook, heat destroys folate. So the only good source of folate is fruits, which I don't cook. Again, barbecue pineapple is not good, right? Which I don't cook, or greens, which I don't cook. We don't eat salads that much, but fruits is reduced a lot. That's the reason I have increased the consumption of folate to pre-consumption period or at the time of consumption, right? 3 months of extra folate because we screwed up the diet, right? So if there's no fruits or greens, there's a very high chance of folate deficiency, right? Next, patient having an neurological deficit. Which of these two will have neurological deficits? B12 or folate? This also is a very important differentiating point. B12 have neurological deficit. Folate will not have a neurological deficit. There will be no neurological deficit in folate. And last but not least is methylmalonic acid levels, right? MMA levels, methylmalonic acid. Okay, because B12 is involved in the biochemical reaction of methylmalonic acid, and it will be elevated in case of B12 deficiency and not be elevated in case of folate deficiency, right? So the answer to this is methylmalonic acid. I think I have given the wrong answer in the test. Ignore that. The answer is option C. That helps me to differentiate folate versus B12. This is common, and is not even seen in case of an IDE, right? Okay, ignore that error. Fine. It's a very simple question. It's a PYQ. What's the answer? What's the answer? I'll ignore that answer. A is neutrophil, right? B, lots and lots of pink granules. That's your eosinophil, right? D is small round cell, single lobated, no granules. That's your lymphocyte. C is your kidney shaped cell. That's your monocyte, right? So A is neutrophil, B is eosinophil, C is monocyte, D is lymphocyte. Option A is the right answer, right? These questions are also again very simple and easy, but please be patient. Don't get confused with the A, B, C, D options, too many things going around. Please be patient, you'll be able to write the correct answer. Fine. Perfect. Antibody, which is diagnostic of Graves' disease. What's the answer? Graves will have antibodies which will be against TSH receptor. But the only thing in Graves is it will be an activating antibody. It's not an antibody which will destroy the receptor. We have something called an TSI. TSI stands for thyroid stimulating immunoglobulin. They will bind to the receptor and they will act like a thyroid hormone. It's a stimulating immunoglobulin. It will not destroy the receptor. It will activate the receptor. That's why Graves has hyperthyroidism, right? Anti-TPO, which one? Which disease will have anti-TPO? Anti-TPO will be seen in case of an Hashimoto's thyroiditis, right? Thyroglobulin also to some extent Hashimoto's, but anti-TPO is more diagnostic of an Hashimoto's thyroiditis, right? Anti-endomysial, not related to thyroid. Which disease? Which disease will have anti-endomysial antibody, anti-TTP antibodies? Which disease? Anti-endomysial, anti-TTP, anti-gliadin will be seen in case of celiac disease. That's a gluten sensitive enteropathy, right? We have anti-TTP, anti-endomysial, anti-gliadin antibodies, right? So all those are seen in case of celiac disease, right? Okay. Again, a one-liner. Just remember the TSI is stimulating immunoglobulin, not a destroying immunoglobulin here. Fine. Okay. This we did read in one of the explanation in one of the Proto-oncogenes question. JAK2 is most commonly seen in which of them? JAK2 is most commonly seen in polycythemia vera. But if the question says JAK2 is seen in which of the following conditions? All these three. All B, C and D All of them are positive for JAK2. Okay, but polycythemia vera is positive in close to 100% of the cases. Right? That's most common. But polycythemia vera, essential thrombocytosis, myelofibrosis, all of them is positive for JAK2. Polycythemia vera is a little bit less common in case of JAK2. It's more common in case of JAK2. Other two are a little bit less in incidence. Fine. So one line again, we discussed this before. Okay. This is a question which came in a NEET exam. Quite a few of your seniors wrote the answer wrongly. Let's see how to solve this. Tell me the answer first, what comes to your mind, then let's look at the other options. What's the answer? Okay, Rahul has gone with B, 3 with B. Okay, now let's look at the question. Before that, few initial insights. Malakoplakia is a chronic inflammatory condition of a bladder. Okay, hemorrhagic cystitis, as the name says, it's an inflammation of the bladder, right? One more information, malakoplakia has a microscopic finding called as 𝐒𝐿𝐼𝐀𝐄𝐝 bodies. This came in recent INI as well. The 𝐒𝐿𝐼𝐀𝐄𝐝 bodies, fine, it's an inclusion body, fine. Now, I'm having a 50-year-old person with a history of hematuria. All of them here can cause hematuria. Prostatic cancer, unlikely to cause hematuria. Prostatic cancer, what will be the symptom? Urgency, frequency, like your benign prostatic hyperplasia, right? And a cystoprostatectomy was done. For a patient with a hematuria, they are doing a radical surgery of removing both the bladder and the prostate. Will anyone do it for an inflammation? No. Right? No one is going to remove the bladder and prostate for an inflammatory condition. I will treat with anti-inflammatory drugs or antibiotics if it's a bacterial infection, right? This already ruled out because symptom is not there. Just with the first two things, I don't even want the image. There's only one possibility, which can be urothelial cancer, right? Now let's look at the image. If you look at this image, there's actually a cut section of a bladder. This is the wall of the bladder. This is the wall of the bladder. This is the lumen of the bladder. In the entire lumen, you have a tumor filling the lumen. It's a mass. It's looking like multiple tiny masses, right? None of the other options will give it the mass. Fine. It's very simple. If a new question comes in an exam, don't even look at the image. If you look at the image, you will goof up. History. History is more important. What procedure is being done? That's enough for me to solve the question. Nothing else is required, right? Just be a little bit calm and patient. That is the most difficult thing, and try to use your common sense than what you read in the last 6 months, right? Hematuria, one is out. Cystoprostatectomy, other two things are out. It has to be urothelial cancer. Now, I will look at the image and correlate. Yes, it fits because I have a mass which is filling the entire lumen of the bladder. It has to be urothelial malignancy, right? And just one more related question which can come in surgery. Which vaccine can be useful for urothelial cancer? Or is a treatment, one of the type of treatment for urothelial cancer is giving that vaccine? It's BCG, right? BCG can help. You'll read that in surgical management of urothelial carcinomas. It's one of the for low-lying tumors. They use BCG as a treatment. Fine, perfect. This is a simple question. Answer. So one-liner. Very simple question also come in an exam. Don't overthink and write the wrong answer and come. It's factor 12. Factor 12 is the H-man factor, right? What's the function of factor 13? Factor 13's function. Factor 13 function is a fibrin stabilizing factor. It's not involved in fibrin formation, it's involved in stabilizing fibrin, right? Which means when I fall down, can I say for the next 2 days, the blood clot will be there? That's what results in wound healing, the scab, right? Okay, it's fibrin stabilizing or clot stabilizing factor, fine. Now, why I said this is, it's a very, very important thing. Can I say that factor 13 is not involved in clot formation? Is that statement right? Factor 13 is not involved in clot formation. Yes, no. Absolutely right, right? So which means if there's a factor 13 deficiency, can I say clot formation will be normal. Clot will not be stable, but clot will be formed, right? So in factor 13 deficiency, your PT, APTT, thrombin time, everything will be normal because clot is formed. Clot is not stable. Symptom also will not be due to clot formation. It will be clot stabilization is the problem, right? So it's very, very important. So now clot is not stable. So now tell me, when will the patient have the bleeding? Immediately after the injury or maybe 1 day, 2 day after the injury? Immediately I got a cut, clot was formed, perfectly normal, bleeding stopped. But after a day or two, clot is not stable, clot will move away. You'll have a delayed bleeding, right? That's a very classical symptom. Whenever a question says delayed bleeding from wound, again, remembering the same concept, what's the first wound what we all of us got? Or what's his first scar we all of us got? Umbilicus, right? Delayed bleeding from umbilical cord stump, right? That's a classical symptom or the first symptom of an factor 13 deficiency, right? It's a very classic delayed bleeding. Delayed separation of umbilical cord was LAD1. Delayed bleeding from umbilical cord is for factor 13 deficiency because there's a fibrin stabilizing problem. Fine. Okay, next question. This is again a very, very simple question. You don't require anything, right? Young child, white reflex in the eye. Nothing else is required. What's the only tumor here which can happen inside the eye? Rhabdomyia cannot happen inside the eye. Ewing's cannot happen inside the eye. Medulloblastoma cannot happen inside the eye. Only thing which can happen inside the eye is retinoblastoma, right? This also is an MCQ. Remember that flex nerve intestinal rosets is also a classical MCQ which can come in retinoblastomas. Fine. Okay. Next. It's a true roset, right? What's the answer? Now let's go on the D. A 10-year-old person brought to the OPD with swelling of face, had proteinuria, cholesterol levels are very high, oval fat bodies are seen in microscopy. The answer is a classical D, right? What's the diagnosis here? If you have to ask what is the diagnosis, what will be a probable diagnosis? Child with nephrotic syndrome, I'm going to think for minimal chain disease, right? Minimal chain disease is the diagnosis for child with a nephrotic syndrome. Fine. Okay, perfect. Now let's have a quick look at the differences between nephrotic and nephritic syndrome. Most of you must have already known it. I'll have here a massive proteinuria, which is more than 3.5 grams per day. Only then I'll call it a massive proteinuria. Mostly they'll be selective. There's a possibility of non-selective also, not required for an undergrad. Selective albuminuria. Because of that, the patient will have an edema. Not just protein will be lost, fat also will be lost. Because of that, I have hyperlipidemia. The liver tries to compensate and the fat content elevates. Not just that, we lose antithrombin 3. When antithrombin 3 is lost, there's increased risk of clot. That can also be a symptom of nephrotic syndrome, right? Nephritic syndrome will have nothing of this. Two classical findings. One is hematuria. Other one is hypertension, right? Yes, this also will have proteinuria, but it's non-selective and it's less, like 1 gram, 2 gram. It will never be a massive 3.5 gram and more proteinuria, and albumin will not become reduced in case of a nephritic syndrome. Fine. Okay. Nephritic and nephrotic, totally different pathogenesis, totally different things. Once you finish your FMGE exam, let's come back and read more things about glomerulonephritis because they are completely logical. If I know where the problem is, you can tell exactly what will happen to the patient. Light microscopy, electron microscopy, immunofluorescence, everything. Fine. Okay, next one. Diagnosis. A 52-year-old person, weakness of upper limb, feeble peripheral pulses. Okay. Nothing is A. Okay. Biopsy of a large vessel is showing giant cells and granuloma, temporal arteritis. What's the most common symptom of temporal arteritis? Can anyone tell me what's the most common symptom of temporal arteritis? Headache, right? Headache is the most common symptom of temporal arteritis, right? Okay, Aryan has gone with C. Let's see why A. I gave an option as A. This time I'm not wrong. I am right. The answer is A only. We'll see why A, right? So I have two vasculitis. We're going to compare both of the vasculitis. One is giant cell arteritis or your temporal arteritis. The other is Takayasu arteritis. Fine. Here, the commonly involved thing in giant cell arteritis is your temporal artery. Okay. It's commonly involving temporal artery. Then it can go to maxillary artery, can go to ophthalmic artery. Those are the areas where the giant cell arteritis will involve, right? So the most common symptom will be headache. Okay. In Takayasu, the commonly involved artery is subclavian artery. So subclavian artery, since is most commonly involved, it might involve your limbs, feeble pulses. That's why it's also called as a pulseless disease, right? You'll have a pain in the arm. We can have a feeble radial pulse and ulnar pulse because subclavian artery is getting stenosed, right? Okay. This is how we read in your textbooks, right? Remember one thing, this is what my professor once said: diseases don't read textbooks, we read textbooks, right? This is how normally it will present. I am not denying that at all, right? Now, can I say both of them are large vessel vasculitis? Is that statement right? Both are large vessel? Both are absolutely large vessel. So can I say a giant cell arteritis can involve subclavian artery? Yes or no? Can a giant cell arteritis involve subclavian artery? At the same time, can a Takayasu arteritis involve temporal artery? Yes, because both are large vessels, right? Can they involve? They can, right? Now, if a giant cell arteritis involves subclavian artery, what will be the symptom? Headache or pain in the arm? Pain in the arm. If the temporal Takayasu arteritis involves temporal artery, what will be the symptom? Headache. Because symptom is based on the disease, that's all. It's not based on the name. It's based on which vessel is involved, right? I'm just erasing this. So now, both can involve both the places. And both of them, microscopy, I'll have granulomas and giant cells. Because both are chronic inflammation. And this is a very classical finding of VVG stain. VVG stain is an elastic tissue stain. Okay. In VVG stain, you will see break in the internal elastic lamina. Internal elastic lamina is a lining in one of the blood vessels. I'll zoom this image for us to better see it, right? It's like tunica intima media. It's a lining in the blood vessel, right? I'll just zoom it here. Can you see that there's a break here? It's continuous here. And this part is broken, right? Break in the internal elastic lamina is classical for both temporal arteritis and giant cell arteritis. So, and your Takayasu arteritis, right? Now the question is, how do I differentiate then? Both symptomatically can be same, microscopy is same, everything is same, right? The way to differentiate is age. If the patient is less than 50 years old, it's mostly Takayasu. Takayasu happens in the age of 30 to 40s, right? If it's more than 50 years old, it's mostly giant cell arteritis. Okay. You will not get this question in your exam, but I'm just telling you this is how reality is. Fine. So keep in mind, next time, whatever symptom it is, look at the age. This symptom is classical of a Takayasu, but age is 52. Cannot be Takayasu. Has to be a giant cell arteritis. Fine. The option is the answer is option A, because it's the age which determines the right diagnosis. Because both of them, symptomatology is same, microscopy is same, everything else is same. Fine. I hope it's clear. Okay. Option A is answer A. You are right. Fine. Okay. Next. Again, this is purely a one-liner which came once in the INSED exam. If it repeats, you should be able to know the answer. That's all. What's the answer? 6 follicles of minimum 10 cells is required for me to call it an adequate thyroid FNAC, right? Because adequacy is the first thing. Only when I know it's adequate, I can go and diagnose some things. We have adequacy for prostate biopsies, breast FNAC, many things like that. There's an adequacy for a thyroid FNAC, fine. One repeated question: which disease cannot be differentiated or diagnosed on a thyroid FNAC? I'm sure you know that, which is follicular carcinoma of thyroid. You cannot diagnose or differentiate on a FNAC of thyroid, right? Perfect, great. Okay, this again is a very repeated topic. Follicular carcinoma or adenoma, we cannot differentiate that, right? Okay, perfect. I won't tell you what it is. By this time, I'm sure more than you've used the Acute in it, you must have seen all the colors, right? You have lavender, EDTA will be the purple or the lavender color, right? This red color, which is the clot activator. Heparin will be the green color. Sodium citrate will be the light blue color. Okay, light blue actin is for sodium citrate, fine. Most of the serological studies, LFT, RFT, all of them you do in the clot activator, because I need the serum for that, or any serological enzyme, unless everything is done on the clot activator only, fine. These are common colors used. There are few rare colors also. I hope they don't ask this. At least the common ones which is used in routine diagnosis, you should be able to know that, fine. Okay. Answer. Which of the following will have a bulky and a friable vegetation? Vegetations of the heart is again important. There are 4 different types of vegetation. All the 4 are there in the options. NBT, Liebman-Sachs, infective endocarditis, and rheumatic carditis, right? Okay, let's look at the different vegetations here. Vegetations are these. Anything which is irregular, where they are irregular on the valve surface, we call it a vegetation. Valve surface will generally be very smooth. What are these structures? Can anyone tell me what are these structures? The elongated one, those are your chorda tendineae, and this is your valve. If you look at the edge of the valve, they are not regular, they are very irregular, right? The irregularity of the valve surface is your vegetation, right? Okay, that's how vegetation means, that's how vegetation looks like. There are 4 different types of vegetation: rheumatic heart disease, your NBT, infective endocarditis, and your Liebman-Sachs, right? In this, infective endocarditis is the only infective vegetation. Nothing else is infective. This is the only vegetation which is very huge. They are very bulky, they are very fragile, and this is the only vegetation which can undergo an embolus. It can break and it can undergo embolus. Rest everything are very tiny. They are like 5 millimeter, 10 millimeter. They won't break and go. These are very huge, they can break and go, right? Rheumatic heart disease vegetations, they are called as verrucae. That's the other name for that. Okay, they are very tiny, right? And they are sterile. They won't have any infection there. Though rheumatic heart disease due to the bacteria will be seen in the throat, not in the vegetation, right? You might make an error here, because whenever you remember rheumatic heart disease, you remember streptococcus. It's sterile, it's not there in the heart, fine. NBT, non-bacterial. So obviously this is also small, tiny vegetation. Microscopy is nothing but thrombus. So any condition which causes DIC can cause this. If there's a thrombus formation, like Apla syndrome, can have thrombus. Anywhere in the body, I can have thrombus here also. DIC can have it. Any prothrombotic state will have this condition, right? And this is also sterile. This is seen not only in DIC, any prothrombotic state. If there's a chance of thrombus formation, I'll have a chance of thrombus formation in the heart valve as well, fine. SLE is only one guy. Liebman-Sachs is SLE. And this is seen on the both atrial and ventricular surface. Most of them are seen on the edge of the valve. These are the ones which is seen on the both atrial and the ventricular surface of the valves. SK, I'll definitely do it, SK. I think it should be there. I'll share this annotated PDF also. You can give the test in the form of an exam as well. Try that also if it's open, fine. Okay, those are the 4 different types of vegetation which are required. Okay, answer. A. I still have not given the test and answer. Now we should have discussed without the test and answer. Okay. This is really a tough question. If you're writing it for the first time, this is a tough question by default. Again, whenever the question is tough, don't try to head on hit the question. When an opponent is tough, try to find the weak points, dissect it one by one. That's much easier, right? Let's see the question. 30-year-old female with abdomen pain at adnexal mass, CA125 and LDH are elevated. So can I say it's an ovarian lesion? It's a lesion from the ovary, right? I can remove this because papillary serous adenocarcinoma is not very common in 30 years. It's a cancer which is seen a little bit elderly age group, and CA125 will not be marginally elevated, will be very, very highly elevated in case of an papillary serous adenocarcinoma. So I can remove that. What marker will be elevated in choriocarcinoma? Is it CA125 or beta HCG? It's choriocarcinoma. Comes from the trophoblast. It's beta HCG, right? So I can remove this also. I don't have a beta HCG elevation, so I can remove this as well, right? Because beta HCG is the one which will be elevated in any case of chorionic tumors. I can remove that. I can remove CA125 because it will have an extremely high CA125, but question says marginally elevated, so not a possibility, right? Then I have only two options here: dysgeminoma, teratoma, right? Now let's look at the image. Let's look at the gross image. Here microscopy is a bit difficult to identify. Let's look at the gross. Gross, the lesion is solid or cystic? What's your take? It's a solid lesion or cystic lesion? Solid lesion. There's no cyst. We are all agreeing on that fact. I don't have a cyst. It's a solid lesion, right? The term teratoma, if we have used, there are two more terms before teratoma. Can I say we call that teratoma as a benign cystic teratoma? That's how we call teratomas. Teratomas are almost always cystic. Teratomas are never solid. It's a cystic teratoma. Teratoma is always cystic. 95% and above will be cystic. So which means it's not solid. I can rule that out also. So the only option left with me is dysgeminoma. Dysgeminoma is a completely solid tumor. Seminoma of testis, dysgeminoma of ovary. Both of them are more or less same, right? So dysgeminoma, malignant or benign? Can anyone tell me that? It's the most common malignant germ cell tumor. It's not benign. Okay. Microscopy, you will have nests of tumor cells, nests of clear tumor cells. The clearing in the image is due to that. These are clear cells. That's why all these cells are very, very clear, right? And the most important thing is, in the septa, you will have lymphocytes. You'll have lymphocytes in the septa. That's also a very classical finding for dysgeminoma. Fine. And like I said, in the gross, they are very, very solid lesions. IHC has changed a lot these days. 2 years back, you had an FMGE question, which is the marker which is used in reality today. It's not available in most of the UG books, right? They have asked that also, right? They are CD117 positive. Dysgeminomas are positive for your OCT3/4. Nano, these are good markers. The recent marker which is used is SAL4. This came in one of the exams. SAL4 positivity. Remember, so these are something which are very rare. Recent advancements, not very important. Consider the rest. If it's repeated, you should know that. That's all. There's a marker called as PLAP. PLAP is a very insignificant thing. If a examiner who's in 60 years old not open the book, ask a question, it might come in exam, right? Because PLAP has 50 to 60% accuracy. This is close to 100% accuracy. Why should I use PLAP? No pathologists use PLAP, but still PLAP is keep on doing circles in your exam purpose, because gynecologists also take this question, right? If I'm a pathologist setting the question, it will be OCT3/4 nano and the recent one SAL4. PLAP is not useful, but yes, PLAP also is positive in case of an dysgerminoma. Just remember that. Fine. Okay. A simple question. What's the answer? Rahul has gone with B. B, it's a very simple question, right? There are few clues. Always go with history. 10-year-old, not possible. Chondrosarcoma happens in 50 plus age group. Okay. Giant cell tumor happens around 20 to 40 years of age. That itself will rule out two things, right? Osteoblastoma can happen in children. At 10 years might be a bit unlikely, but second decade it can happen. 12, 15 years around it can happen, right? And osteosarcoma, right? I'll zoom this image. Now tell me, this is the bone, right? This is the bone. Is it destroying the bone or not destroying the bone? Destroying and going outside or not destroying and going outside? Undoubtedly destroying, right? 10-year-old, I won't remove the entire femur for a benign tumor. Again, the same clue, same way we use for urothelial carcinoma, right? We have removed the entire lesion for a 10-year-old, so it has to be a highly aggressive tumor. It's osteosarcoma, right? It's osteosarcoma, which is a tumor which happens in children. And what is the gene mutated? This can also come in an exam. Gene is RB gene. If you are done with orthopedics, can anyone tell me the X-ray finding of osteosarcoma? Let's see how good your orthopedics is. Osteosarcoma X-ray findings. Sun ray appearance, sunburst or sun ray appearance is one more thing, one triangle. There are two X-ray findings in osteosarcoma. One's your Hodgman triangle and your sunburst or your sun ray appearance, right? Both these are classical findings of osteosarcoma. Bone tumors, please be very confident in X-ray, because most of the bone tumors are diagnosed by radiology and not diagnosed on pathological basis or gross basis, right? They are, first clue is age, second clue is the location, epiphysis, metaphysis, diaphysis, third clue is X-ray, last but not the least, you have your gross and microscopic, fine? Okay. This is a question repeated once in an exam, just a random rare question. This repeats, you should be able to know it. Rapid assessment of coagulation pathway is done by thromboelastography. Just remember it as a fact. This is an intraoperative procedure. Where it is used is, it's used for most of CTVS surgeries. That's the only place where they use it, or maybe sometimes in case of a neurosurgery. The reason why CTVS and neurosurgery is required is both cardiothoracic surgery and neurosurgery operations go for 6-7 hours together. Very long time. If it's going for a very long time, there's a possibility it's heart, right? Lots of blood will be pushed inside, lots of blood loss will be there. So when I add, let's say I'm giving 10 units of blood to a patient, will blood have clotting factors or not? Because I'm storing the blood for 30-20 days. Clotting factors will go away. I'm giving only RBC. I'm not giving clotting factors. So all these surgeries has a risk of coagulation abnormalities because of recurrent blood transfusions done. Intrinsic risk of coagulation abnormalities, right? That time I cannot rely on PT APDT, because for me to do PT APDT, it requires minimum of half an hour. Minimum of half an hour, because I have to centrifuge, then do it. Thromboelastography can give the statement within 90 seconds. Right? So obviously that's much more better in these conditions compared to the rest of the conditions. We don't use thromboelastography for any other condition. Any long-term surgery where there's a risk of coagulation, immediate input it can give. It can give approximately 90 seconds, can give exactly what's happening. Is it DIC? Is the problem in fibrinolysis? Everything it will give very quick, right? That's why it's very rapid assessment of the entire coagulation pathway. Not used in routine, only used during the surgeries, fine? Okay, the last question. It's a simple one. We had discussed this before. This is the brown color, elongated fiber, and a person is working in a factory with lung fibrosis and thickening. Perfect. That's your classical ferruginous bodies, and that's classically seen in asbestos related disease. Ferruginous bodies and asbestos bodies are more or less the same thing. In reality, it's actually different, but at least for an MCQ purpose, remember them as the same thing, right? This has been repeatedly told to most of you. What's the most common cancer related to asbestos? and the most specific cancer. What's the most common carcinoma related in asbestos? It is lung adenocarcinoma. Okay, adenocarcinoma is more common, and obviously mesothelioma is very, very specific, right? Okay, mesothelioma will never happen in less than 60 years of age. 60 years is the minimum requirement for mesothelioma because it's a very long pathogenesis to happen, right? Once you see mesothelioma, some amount of asbestos exposure will be there. Without that, mesothelioma will never happen. That's why it's a very, very specific thing for mesothelioma. Fine. Okay, that's about asbestos, and we have come to the end of the T&D. Okay, so this PDF will be put up in the Telegram channel. They have put that also in the PPT. Okay, I'll share this PDF. I'll share it with Anish. Anish will share it with you. So if you have any questions, you can ask. Thank you for your patient time. It's close to 3.5 hours. Amazing determination. Do the same thing, just one more month, right? I was not available for a few days for the daily 10 a.m. We'll start it from tomorrow, right? The functions and pujas and everything kind of messed up the schedule. I'll definitely come from tomorrow 10 a.m. Let's see what we are going to and how we are going to do it. Fine. Great, guys. All the very best. Do well. See you soon. And by December, I hope the session comes soon. By Jan, we'll be doing the next thing. Go to internship. Let's crack NEET PG as well. Fine. Yes. Sorry, Nathan. Okay. I'll definitely come from tomorrow. Okay.